Hello all. Welcome to the second day of the INICET PSM discussion on Medico. I'm Dr. Sumna. So today we are going to discuss some of the very recent updates in community medicine, as well as some of the very highly repeatedly asked questions. So with that, let's start learning. Moving on to the first question of the day. Swastnari abhiyaan. So that's something new. The Swastnari abhiyaan primarily focuses on options you have are family planning services, maternal mortality reduction, preventive screening for women's health issues, and adolescent health. So remember, Swastnari abhiyaan is a new campaign. It is mainly aiming for women's preventive screening. So it's a preventive screening initiative. So here your option C is going to be the correct answer here. So remember, Swastnari abhiyaan is a new initiative by the government of India. It's like a campaign. It focuses on preventive screening in women. So mainly the common diseases in women and some of the things which can be screened and prevented, like which are the cancers common and which can be screened and prevented. Your CA cervix, then CA breast. So breast and cervical cancers come under this. Then anemia. Anemia is another common issue in women. So anemia is there. Then we have osteoporosis. Then your diabetes and hypertension. So these are the main diseases under Swastnari Abhiyan. And we have special campaigns for and camps are being organized for the screening of these particular diseases. So Swastnari Abhiyan, when you hear Swastnari Abhiyan, remember it is primarily a women's preventive screening initiative. So this is the logo for Swastnari Abhiyan. So this is actually not just by the Ministry of Health and Family Welfare. This is a collaboration between the Ministry of Health and Family Welfare as well as your Ministry of WCD, Women and Child Development. So you have Ministry of Health and Family Welfare plus Ministry of Women and Child Development, both combined for this particular jointly implementing this Abhiyan. And this campaign includes health camps conducted across states and union territories. Then we have screening. Where does the screening happen? Screening happens at your Ayushman Arogya Mandir. What is Ayushman Arogya Mandir? It's nothing but the changed name of your health and wellness centers under your Ayushman Bharat. So we have sub centers, we have PHCs, which are upgraded to Ayushman Arogya Mandir. So there you have screening for all the diseases that I've just mentioned you. Not just there, we have screenings at the CHC level, district hospital level also, and focuses on mainly on the women and child health, and particularly on cancer screening, NCD screening, and anemia. So this was about Swastnari Abhiyan. Okay, we'll move on to the next question. So India was declared free from which disease as a public health problem in 2024? So they have specified a year, 2024. And among the diseases listed, you have, which are the options here? Leprosy is there, trachoma is there, yaws is there, guinea. So India was declared free of this particular public health problem recently, that is in 2024. Which is the answer? Is it leprosy, trachoma, yaws, or guinea? So the answer here is option B, trachoma. So see, this is the elimination of trachoma as a public health problem. India was certified from WHO that we have eliminated trachoma as a public health problem in 2024. So a few words about trachoma. Tell me, what is the causative agent? Trachoma is caused by chlamydia, trachomatis. Then it is the leading cause, or trachoma is the leading infectious cause of preventable blindness. That's an MCQ for you. So which is the leading infectious cause of preventable blindness? That is trachoma. Now, India has achieved elimination of trachoma as a public health problem through a strategy. What is that acronym, or what is the strategy called as? All of you would have heard it. It is the SAFE, S-A-F-E, SAFE strategy for trachoma elimination. What does SAFE stands for? We have S-A-F-E. S is for surgery. A, it's an infection, so you need to give antibiotics. F is for facial cleanliness. And E stands for environmental improvement. So that is your safe strategy. Now let's see what are the other options given. So what about leprosy, yaws and guinea worm? See, leprosy has been eliminated in India. That is true. But in your question, they've asked you particularly in 2024, recently. So leprosy elimination happened around 2005. That is not your question that has been asked. So leprosy has been eliminated as a public health problem at national level, not subnational level. At national level, it has been eliminated in 2005. That means to eliminate the leprosy or to say that leprosy has been eliminated, we have a criteria. That is the prevalence is less than 1 per 10,000. That we have already achieved in 2005. So leprosy is out of this question. And one more point I would like to say is the program. We have the National Leprosy Eradication Program. When I say NLEP, the program we have is National Leprosy Eradication Program. Why? Because we have already eliminated it. Now our aim is to eradicate leprosy at the national level. Now trachoma is the answer here. And what about yours? See, yours, India is eliminated in 2015. And guinea worm disease, India was certified free of guinea worm disease in 2000. So here the best answer would be option B, which is trachoma. Now moving on to the next question. Next is a favorite area for the examiners, that is TB. So under TB Mukt Bharat Abhiyaan, so we are here with another Abhiyaan, just like your Swastnari Abhiyaan. This is your TB Mukt Bharat Abhiyaan. So under TB Mukt Bharat Abhiyaan, Nikshay Mitra primarily provides what? Option A, drug therapy. Option B, financial incentives to doctors. Option C, nutritional and social support. Option D is diagnostic services. So what does this Nikshay Mitra means? What do you mean by Mitra? Mitra means friend, right? So Nikshay Mitra is nothing but a person or an organization or an institution who can be a friend to your TB person, to the TB patient. So you have a TB patient and a friend to this TB patient is what you call as Nikshay Mitra. So it can be either individual or it can be organizations or institutions. See, they can actually adopt a TB patient and provide support. What kind of support? Do they need to give drug therapy? Drug therapy is already given free of cost from the government side. Now your friend doesn't need to provide it separately. So option A is wrong. Now financial incentives to doctors. See, Nikshay Mitra, they are friends of patients, not for the doctors. So they don't have to provide any money to the doctor. Diagnostic services, no. Again, diagnostic services also are given free of cost from the government side itself. So your Mitra doesn't have to give. What the patient needs from the friend is nutritional and social support. So that is the answer here. Your Nikshay Mitra, primarily, they provide nutritional and social support. So if you want to be a Nikshay Mitra, you through the program, you adopt a TB patient or someone and you provide nutritional support, social support, vocational support. So all kind of support you give to the patient. So that is what you call as the Nikshay Mitra, which came under the TB Mukt Bharat Abhiyaan. Okay, so I hope that is clear. So if I say it in a one line, just as a one-liner, your Nikshay Mitra is a community support system for TB patients. Okay, I hope that is clear. Now, what is this logo you see here? We all know the logo of NTP. I hope you all know the logo of NTP. This is not the logo of NTP. This I'm showing you is the Pradhan Mantri TB Mukt Bharat Abhiyaan ka logo. Okay, so here it is actually a campaign which was introduced by the government in 2022 in order to achieve the targets of NTP. So your NTP is a program, that is National TB Elimination Program. So according to NTEP, the program, we were supposed to eliminate TB by which year? By 2025, which was 5 years ahead of the global target. So what was the global target? The global or the WHO target for TB elimination was 2030. So our government told, no, we'll eliminate it 5 years before. That's in 2025, which we have not done. So our target was 2025. To speed up this, they brought up a abhiyaan or a campaign. That is what we call the TB Mukt Bharat Abhiyaan. So this came up it was launched in 2022. And the campaign promotes what you call as the Jan Andolan. That means in Hindi, it means people's movement. So it's like it's a movement against your TB disease through community participation. That's what they mean by this people's movement or the Jan Andolan. So the TB Mukt Bharat Abhiyaan and some more latest points with regard to TB that you should know and which was introduced in the latest guidelines as well as in this Abhiyaan. Point number one. So point number one is your Nikshay Portion Yojana. So this is an example for DBT. What is DBT? Direct Benefit Transfer. So what happens is when there is a patient with TB, he or she has to get registered in the which portal? Nikshay portal. Nikshay means no TB. Kshay is TB, right? So in the Nikshay portal, once the person is registered, they are getting an amount. That is, initially it was 500 rupees. 500 rupees every month has been transferred directly to their bank account. That is what we call as the direct benefit transfer. No need of any intermediate or no, they don't have to come to the hospital or anything. Once they are registered, they get the money every month directly into the bank account, which is called as the DBT or direct benefit transfers. So this every month. So if the treatment is for 6 months, for each of the every month till that 6 months period till he takes the treatment, the patient gets 500 rupees per month. So that was 500 rupees initially. As of now, as per the latest update, 500 has been increased to 1000 rupees. So remember, Nikshay Portion Yojana, the amount they get, the patient gets every month is not 500, it is 1000 rupees. This is a recent update. Please note. So as of now, 1000 rupees is given every month through direct benefit transfer to the TB patient. And the scheme is called as Nikshay Portion Yojana. That is one point that I wanted to tell you. And I hope you all know that TB notification is mandatory in our country. And the portal name is Nikshay portal. Similarly, we have a Nikusht portal that is for Kushta. Kushta is leprosy. So Nikusht portal is for your leprosy. Nikshay portal is for TB. Now moving on to the next question. So a woman suffering from active tuberculosis, not on ATT, that means she is currently having active TB, has a full-term vaginal delivery. All of the following should be done except breastfeed the neonate. BCG should be given to the neonate. Neonate should be given INS, that is isoniazid. Neonate should be isolated from the mother. So which you are not supposed to do. So should she breastfeed the neonate? Yes, she should breastfeed the neonate because even breastfeeding gives a lot of immunity to the child. So you cannot deny the breastfeeding. Even though the mother has TB, she has to breastfeed the neonate, but she has to maintain all the precautions, like she has to wear the mask and everything so as to avoid the spread. But breastfeeding has to be done. You cannot deny that. BCG should be given. Of course, it should be given even if the mother has TB or not. BCG is given to every child born in India as a birth dose. BCG is given at birth. Okay. And one more question here. BCG can be given up to which year? See, BCG can be given up to 1 year of age. Suppose a child misses the BCG vaccination at birth due to some reason and comes later to you. So up to 1 year of age, BCG can be given. Beyond 1 year of age, there is no point in giving BCG. So you don't give it. Then neonate should be given INH or isoniazid. Definitely yes. This is the treatment or this is the prophylaxis that we can give the child. So a baby born to a mother with TB should be given INH as well as BCG. Now, neonate should be isolated from mother is the wrong answer here. You shouldn't isolate the neonate from the mother. If you are isolating, it actually adversely affects the feeding, everything gets affected. So baby should not be isolated from the mother, but you have to provide INH to the baby. Then the mother has to be started on ATT, it's antitubercular therapy, and breastfeeding has to be continued, but do not isolate or do not separate the baby and the mother. So option D is the correct answer here. Now, when I talk about ATT, anti-tubercular therapy. So what is the treatment regimen followed in India as of now, whether it's a pregnant woman or I'm talking about the pulmonary TB, not the not the drug resistant TB, a simple drug sensitive pulmonary TB. What do you give? We give under the program 2-HRZD plus 4-HRE. What do you mean by this? 2 months is intensive phase where you give 4 drugs, that is HRZD. Isoniazid, rifampicin, pyrazinamide and ethambutol. Okay. After the 2 months of intensive therapy, you move on to the continuation phase, that is 4 months of HRE. Okay, that is isoniazid, rifampicin, and ethambutol. So that compromises the 6 months. Okay, that is the treatment for tuberculosis, a pulmonary tuberculosis, which is drug sensitive. Now, confusion comes is some of you would have heard that we have a WHO recommendation which says a 4-month therapy instead of the 6 months. We have a 4-month regimen. So that even though that is an update, please don't get confused. Under the NTEP, we are still following the same thing, that is 4-2-HRZD plus 4-HRE, a treatment for 6 months. The one we are talking about, or the one that is confusing you, is what I'm going to tell next. So WHO has recommended a 4-month regimen for tuberculosis. But see, this is just a recommendation. This has not been adopted into the program, and it is not very easy to just adopt a recommendation when WHO says, because India is a big country, programs running on a bigger level. There are many aspects to check before you implement some recommendation into our country. So WHO 4-month regimen is just an update from WHO. But in your questions, stick on to the NTP 6-month regimen. 6-month regimen is still followed. We have not changed it. So what does WHO 4-month regimen says? It says that the treatment is instead of 6 months, you give for 4 months only. And the drugs are also changed. 2 months, first 2 months you give HPZM, and next 2 months you give HPM. Basically, from the HRCT and HRE, they have changed 2 drugs. Instead of rifampicin, they have changed it to rifapentin. And instead of your ethambutol, moxifloxacin. This is the change in the WHO 4-month regimen. So rifapentin and moxifloxacin instead of your rifampicin and ethambutol. That is the change. And this has been recommended. It's just a recommendation by WHO. It is not yet routine in program. And only advantage is that it has a shorter duration. So we are hoping that it will give up better adherence. But the limitation is it's still in the scaling up process. We need to have more trials and everything before you implement it. And one difficulty is, see, we are talking about moxifloxacin. So TB, as far as TB is concerned, one of the major issues that we are facing is drug resistant TB. So we have a lot of drug resistant TB happening now, right? So if I'm giving moxifloxacin in my TB treatment, moxifloxacin is an antibiotic which we usually give to the patients. Otherwise, also we give moxifloxacin, and people would be taking it for some days and stopping it. They would be getting it over the counter. So there's a chance that people already have drug resistance to moxifloxacin. So if you want to start a moxiflox containing TB regimen, when a patient comes, you have to do the drug susceptibility testing for moxi first. Then only you can start it. If its patient is already sensitive, there's no point in giving this. Okay. So there are like different practical difficulties associated with this when you have to change it to moxiflox, because then you have to do the drug susceptibility testing, and many other factors are there. So you can't just change the regimen all of a sudden. So in a question, if you get for this INICET exam, please don't write this WHO 4-month regimen here. Go with the NTP 6-month regimen, that is 2-HRZD and 4-HRE. There is no change in that. Okay. I hope that is clear to you. So some more points from the NTP. So this is the logo of NTP. As far as the PSM is concerned, all logos are very important, especially all the national health programs. You'll get a logo, directly question to identify the logo, or he'll give you a logo and ask a associated question. Okay, so this is the logo of your national TB elimination program. Remember, it is elimination, it's not eradication. Some points. So NTP works on 4 pillars, or what are the 4 strategic pillars of NTP? We have detect, treat, prevent, and build. These are the 4 pillars of NTP as per the program. So we'll just write it down. So first point for you to remember is the 4 pillars include detect, treat, prevent, and build. So these are the 4 pillars of NTP. Now we talked about the INICET portal. So every person has to get registered under this portal. And it is used for, TB notification, tracking of the patient, TB adherence, everything. We make use of the INICET portal. That's the second point. Third point. What is the TPT? What do you mean by TPT? TPT is TB preventive therapy. That is the household contacts of TB or close contacts of TB. You can give TB preventive therapy. Okay. Because patient may be infected with TB. TB is a highly contagious disease. So you don't want that, latent TB to convert to a full-blown TB. So you can actually give TB preventive therapy. But before you give the TPT, make sure or rule out active TB. Somebody has an active TB, you give the TPT, that's going to give a bad outcome. So first thing, make sure the person is not having active TB or rule out active TB, and then you can give TPT. Now we have two regimens for TPT as of now, which is first one is the 3HP regimen. Second one is your 6H. What do you mean by 3HP? 3HP is weekly HNP, that is isoniazid plus rifampicin, not rifampicin, rifampicin for 3 months. That is what you mean by 3HP regimen. The other one, 6H is what? Isoniazid. So 6 monthly isoniazid, or sorry, it is daily isoniazid for how many months? 6 months. That is what you mean by 6H. So these are the two regimens under your TPT or TB preventive therapy. And now we are trying to decentralize all the the services given for TB through Ayushman Arogya Mandirs or AAM. Now, what is this BPAM regimen? That is another update I would like to tell. BPAM regimen. Where have you heard this? See, BPAM regimen is a latest regimen, latest update, and this has been accepted in the NTP also. BPAM regimen is your short, completely oral regimen for drug-resistant TB. So when I'm talking about drug-resistant TB, if you have studied initially, we had more complex regimens, more tablets, more medicines were there. They included injectables also, and it is very difficult, for the compliance, because patients won't prefer longer regimens, so many drugs to take with injections. Definitely there will be lesser compliance. So we have a solution for that. That is your BPAM regimen. What is BPAM stands for? B is your bedaquiline, pretomanid, linezolid, and M is moxifloxacin. So this is BPAM regimen for drug-resistant TB. This is a 6-month. It's a 6-month all oral regimen. So this is also one of the update from TB. You can expect a question on BPAM regimen. This is the same thing. This was the approved. This is the news clipping where the Union Health Ministry approves a shorter and more efficacious treatment for drug-resistant TB, which is your BPAM regimen. Okay, and this is the latest national guideline for management of drug-resistant TB. It has been accepted here also. Now, last point, not last point, we have two more updates from TB. So what is this CYTB, site TB? You would have heard about this. What is this CYTB or the site TB? This is also a latest update under the NTP program. So this is basically a skin test, just like you have your Manto test, which is skin hypersensitivity test for TB. To check the latent TB infection, we have the Manto test, right? You do the Manto test and then you see for the induration. What is the major disadvantage of Manto test? If somebody has taken BCG vaccine, Mando can actually give false positive result. Okay, that was one major drawback or limitation of your Mando test. This site TB or the CYTB test actually overcomes that disadvantage, because it has it is used against specific TB antigens which are actually absent in the BCG strains. So what happens, even if you have taken BCG or not, if you have latent TB, there is no false positive because of the BCG vaccine, you get a proper positive test if you have latent TB. That is your site TB. I'll just write down the important points under site TB. This has been accepted in the program. It is the latest update. So CYTB is a skin test to detect latent TB infection. I told you about the TPT, TB preventive therapy. So for that, we have to rule out the active TB, and to detect latent TB infection, we can make use of this site TB test also. It's similar to Manto, but it uses specific TB antigens. So it detects specific TB antigens. They are the ISAD6 and CFP10. So reading and all is just similar to your Mando only. That is after 48 to 72 hours, just like your Mando test, you have to read it. And make sure that or understand that this is detecting latent TB. It is not for active TB infection. Okay. actually kidney disease. Advantage is actually it's actually cheaper and it's a simple alternative for your IGRA also in some of the settings. So this has been used in some of the settings. So that is another update from TB. Now going to the last update from TB for this today for the day. What is Kushi? Kushi means happiness, right? So Kushi is your it's a chatbot. Just like you have your chat GPT, Kushi is a chatbot which is integrated into your TB Mukt Bharat app. Just like our TB Mukt Bharat Abhiyaan, there is an app that is the TB Mukt Bharat app. So in that app, you have a chatbot that is Kushi. She's a multilingual AI chatbot. So you can ask the patients, they can or anybody can basically type and ask their doubts regarding the TB treatment or say about some of the side effects. Just like you ask your doubts to ChatGPT, they can ask the Kushi chatbot. And it's a multilingual thing. So it can understand 12 regional languages in India, both text message as well as the voice comments. And it's actually integrated with the Nikshay portal also. So to set daily medicine alerts and all goes from this. And usually it gives instant replies to all the questions on TB symptoms, side effects, nutrition, everything. It's a real-time GPS. Okay, it acts as a real-time GPS also to guide patients to the nearest Ayushman Arogya Mandir. So they want to know where I can get the treatment or which is the nearest Arogya Mandir where I can get tested and all that. That details is also enabled in the Kushi chatbot. So remember the name, this Kushi, KHUSHI, Kushi chatbot or e-Sangini. It's a AI linked chatbot under the TB Mukt Bharat app. So next, we'll move on to the next question. So I hope TB updates are clear to you. Next question is, okay, NOVA classification, NOVA classification classifies foods based on option A, nutrient density, option B, degree of food processing, option C, glycemic index, and option D, calorie content. So what is NOVA food classification? This is the latest, not that latest, but recently INICET has asked questions regarding this NOVA classification. So it's gaining importance. Okay. So NOVA classification is basically a system to classify foods based on option B, that is degree of food processing. So based on the degree of food processing, whether your food is completely processed or minimally processed or ultra processed, you have a classification which is called as the NOVA classification, and it actually categorizes food items based on the extent and purpose of food processing. So you have 4 classes of foods under the NOVA classification. Let's see that. So this is this image is showing me the NOVA classification, NOVA food classification. Group 1, Group 2, Group 3, and Group 4. What is Group 1? Group 1 is the most healthiest and the good food that you should be eating. So that is unprocessed or minimally processed foods. You can see on the image, right? These are the pure food items that you get without any processing. It can be fruits, vegetables, egg, milk. Those unprocessed foods form the Group 1. Now, Group 2 are actually, minimally processed, or we call it as culinary ingredients. These are extracted from the Group 1. So these items in the Group 2, you can see honey here, you can see butter, olive oil and all that. So these are basically extracted from your Group 1 food items. And these are actually added in your cooking, maybe to add increased taste and all that. So your salt, your sugar, butter, oil, ghee, honey, all those things come under the Group 2, which is basically the items extracted from Group 1 and used in cooking. Now, Group 3 has Group 1 foods. Group 3 involves the processed food items. These are Group 1 foods added with salt, oil, and sugar. So, Group 1 to the Group 1 items, if you add these items, salt, sugar, and all, if you add these items and then process it, that becomes your Group 3 food item. So, you can see the examples here. Your, salted items, sugar items, all those things comes under the Group 3 processed food. Now the Group 4 are ultra processed food, which is completely made by the industry. Industrial made ultra processed food items come under Group 4. There is no need to memorize anything which comes under Group 4. almost all the food items which you love, which you consider as junk food, which you use for binge eating, your kurkure, your lays, your Maggi, your soft drinks, sweets, ice creams, everything comes under your group 4, which is ultra processed food. The repeat question is ultra processed foods comes under which group? That is group 4. Okay. So I hope that is clear to you. And high consumption of ultra processed food is leads to or it is associated with diabetes, obesity, and different cancers as well as cardiovascular diseases. So we have to reduce the ultra processed food. Just like your ultra processed food, there is one more special food item. Again, it's just another name which has recently gained momentum in your NI National Institute of Nutrition guidelines also. So that guidelines also tells you to avoid something called as HSSs. HFSs. What is this? It is high fat. What will be the two S which we are supposed to avoid or not take in excess? It is sugar and salt, right? So it is high fat, sugar, and salt containing food, which are termed as the HFSs. So these are also energy dense but nutrient poor food items. Again, all those comes usually all those that we put under the ultra processed food items, which I told you, the ice cream, Maggie, or Lays, everything comes under your HFSs also. Again, this is also known to cause obesity, diabetes, hypertension, cancers, and cardiovascular events. So that was about the HFSs and ultra processed food. So remember the name of the classification, that was NOVA classification. Moving on to the next question. This again, it's the recent talk of the town. Yes, we're talking about the census 2027. So the question is the next census 2027, or it's the 2027 census. You don't need to know the next. Next is one is the one that is recently happening. It's already started, is 2027. So the census 2027 of India will be conducted with which major new features? So what is special, or what is the new update regarding our census 2027? Option A, only paper-based. Option B, entirely Aadhaar linking mandatory. Option C, digital data collection. And option D, only rural population. So let's rule out options and then let's find out the answer. Only rural population is absolutely wrong. Whether it is census 2027, 2011, whichever census means universal sampling. That means everyone has to be included in the census. The only study or the only procedure where we collect data from every individual or we use the universal sampling is census. Okay, so census usually occurs once in every 10 years. Last census was supposed to happen in 2011. It happened in 2011, and after 10 years, what happened? COVID happened, and because and then many political issues and all that. So because of COVID and all those, census was delayed, and finally in 2027 we have the present census act. So only rural population is absolutely wrong. Only entirely Aadhaar linked mandatory. See, as per the new census, this is not a criteria. It is not mandatory to link Aadhaar. There is no Aadhaar linking kind of thing in this census as of now. And only paper based is also wrong. The major update or the major feature of census 2027 is digital data collection. Okay, the last census happened in 2011. Now it's a digital era, 2027. We have to digitalize. So digital data collection is the correct answer here. And even it also has a self-enumeration option, meaning we have certain forms which we ourselves can fill. That is self-enumeration means I can fill the detail. Self-enumeration option is also there. And your census enumerators, the people who go and collect the data, they use digital apps. They use the app and they collect the data not on pen and paper, but using tabs and mobile phones. Okay, that is digital data collection. We have the real-time data collection monitoring also happening in this particular census. So that is a major point and major update about census 2027. Okay. So census 27 is going to be, just write down the important points. This is going to be census 2027 is going to be India's first fully digital census. And remember, self-enumeration facility is also available. Next point, any census, we have two major phases. Which are there? You have house listing first. First, you have to list all the houses, right, in a population, in a locality. Next, you have to enumerate the population. So how many houses are there? That first listing is done. Then each house, who all are there? That is the population enumeration. So you have house listing and population enumeration. These are the two major phases in a census. And India follows the de facto method of population enumeration. What do you mean by de facto method of population enumeration? See, suppose I'm from Kerala and during the census 2027 time, say I'm studying in Delhi. Okay, so I'm settled in Delhi at that time. Not settled, I'm staying in the hostel in Delhi. So I will be included under Delhi, not under Kerala. So that is what we mean by de facto method of population enumeration. Wherever I am at that particular point of census enumeration, at that place I will be included. Not because my hometown is in Kerala, I won't be counted there. I'll be counted where I am at that particular point. That is what you mean by de facto method of population enumeration. Okay, who are they? You see a man and a woman on the image. They have a tablet or a mobile phone, a digital device to collect data. They have the ID card, everything. See, these are the mascots for Census 2027. His name is Vikas and she is Pragati. So we have two mascots for the census. This is Vikas and her name is Pragati. So they are our mascots or official mascots of Census 2027. So Pragati is the female census enumerator and Vikas is the male census enumerator. So basically, they were launched to promote or to create awareness that this is India's first digital census. You see a mobile phone, everything in their hand, right? That is showing that this is India's first digital census. Second one, there is self-enumeration. And basically, we are making use of technology-based data collection. And also, it shows gender equality and inclusiveness. It's not just a male person or a female person, both genders are being included. So it's in a way showing gender equality and inclusiveness. So these are all the points about Census 2027. And who conducts census in India? Census is conducted by the Office of the Registrar General and the Census Commissioner in India. These are under the Ministry of, Census is not under the Health Ministry, Census is under the Ministry of Home Affairs. Okay, that is a ministry which is responsible. And census is based on Census Act of 1948. So I've covered some of the most important points about census. With that, let's move on to the next question. So what is this? The health and wellness centers under the Ayushman Bharat has recently been renamed as this. I've already told you before. The health and wellness centers has been renamed as what? AAM or Ayushman Arogya Mantra. Okay, so a few points about the Ayushman Bharat program. So Ayushman Bharat is AB, Ayushman Bharat program. When was it launched? First MCQ. It was launched in 2018. Why? The aim was to achieve UHC. What is UHC? It is not urban health center here. It is universal health coverage. UHC is universal health coverage in India. So Ayushman Bharat program was basically launched with the aim of achieving universal health coverage in India. Okay, in 2018 it was launched and it has two prongs or two major components. What are they? Ayushman Bharat has two major components. First one is your HWC, that is your health and wellness centers, now renamed as Ayushman Arogya Mantra. Second part is your PMJ, Pradhan Mantri Jan Arogya Yojana. So health and wellness centers and PMJ, these two are the major components under Ayushman Bharat. What is health and wellness centers? They are basically focusing on you are upgrading your existing sub-centers and PHCs into comprehensive centers which provide comprehensive primary health care or CPHC. Okay, that is your health and wellness centers. So basically, the primary level of healthcare is being taken care at this level. So you have health and wellness centers now known as Ayushman Arogya Mandir, and we have a CHO, community health officer, appointed at the health and wellness centers. They are usually nursing officers, not a doctor necessarily, can be nursing officer appointed at HWCs. So HWCs, the component of health and wellness centers mainly focuses on the comprehensive primary health care. Okay, and PMJ is providing financial protection. So it's like an insurance scheme under the Ayushman Bharat. So financial protection for not primary. This is for secondary and tertiary level of healthcare. Okay, so that these are the two major components of Ayushman Bharat. Now Ayushman Bharat is implemented by whom? NHA or National Health Authority. So it emphasizes not just on the treatment, but it emphasizes on the preventive, promotive, curative. rehabilitative as well as palliative health services. I hope that is clear to you. Now, this is your health and wellness center, or renamed as Ayushman Arogya Mandir. And this is what I meant by comprehensive primary healthcare. So it has all these components, like from curative, promotive, palliative, rehabilitative, everything. And also in different aspects, like you have, ANC care is there, the neonatal care is there, your mental health is being taken care of. Likewise, oral health care. So everything is there under this Ayushman Bharat Arogya Mandir, or AAM, Ayushman Arogya Mandir, or Health and Wellness Centers. So basically, we are transforming your existing sub-centers and PHCs under Ayushman Bharat. And remember the word comprehensive primary healthcare. Okay, now what is this? The slogan is PMJ, that is Pradhan Mantri Jan Arogya Yojana. This is basically your insurance, health insurance component. Secondary and tertiary hospitalization to eligible families. And how much is the health coverage given? It is up to rupees 5 lakh per family per year. So this is kind of an insurance coverage to families, actually to the families which are like deserving the below the poverty line. Like you choose the families which who are going to get PMJ based on a census, that is the socioeconomic caste census, call it as SCC, socioeconomic caste census 2011. Has already happened in 2011. So based on this data only you decide the beneficiaries, who all are the beneficiaries who should get the benefits from this PMJ. So those people are selected, and they get, if they're selected from certain empaneled hospitals under Ayushman Bharat, if they get treatment, whether it is secondary care or tertiary care, they get cashless benefits. They can, without any cash, they can get treatment from those empaneled hospitals. Amount has been asked up to 5 lakh per year per family is the maximum amount they can get through the PMJ. Okay, I hope that is clear to you. Moving on to the next question. Which of the following is a key component of Ayushman Bharat Digital Mission? So ABDM is Ayushman Bharat Digital Mission. Initially, it was called as the National Digital Health Mission. Now that has been renamed into Ayushman Bharat Digital Mission. So under this, what do you have? Nikshay Portal HMI is IDSP ABA ID. Obviously, it is the ABA ID. ABA ID stands for what? Ayushman Bharat Health Account ID. So you all have an Aadhaar card, right? That is your identity. Just like that, now the government has brought up something called as the ABA ID under Ayushman Bharat. That is Ayushman Bharat Health Account ID. So it's just like a digital health identity. It will have all your health related details. So when you go to a hospital also, it is being linked across health records, or across the health records in different hospitals. And it enables actually paperless health services to the patients and facilitates better digitalization in the healthcare. So basically, it's a digital health ID card for a person. That is called the ABA ID. This has been introduced under your Ayushman Bharat Digital Mission. What are the other options? Nikshay Portal is for what? Nikshay Portal is TB. HMI is Health Management Information System, where you collect all the hospital data. IDSP is Integrated Disease Surveillance System, which is for disease surveillance, especially diseases which are prone to create outbreaks. We have an IDSP portal separate for them. We have different forms. Forms are being filled, and basically to detect any outbreak, we have this IDSP program. That question is coming later on. We'll discuss it there. So here the option is option A. ABA ID is the correct answer for this particular question. Again, ABA ID was launched in 2021 by whom? Same people who are conducting the Ayushman Bharat, that is your National Health Authority. Now we'll just say some of the major digital health initiative. Digital health again is a favorite area for INICET. So digital health initiatives. First one, what is e-Sanjeevani? E-Sanjeevani is India's national telemedicine, launched by the Ministry of Health and Family Welfare, that is e-Sanjeevani. We have two types. We have an eSanjeevani OPD, which enables, doctor to patient consultation through teleconsultation from the home of the patient. Then we have something called eSanjeevani Ayushman Bharat HWC. This is basically, it's a doctor to doctor consultation. So at the primary healthcare level, if a patient comes, if I'm the doctor there, if I want, I need to get a gynec opinion. I'm not a gynecologist, so I can actually get the gynec opinion from the gynecologist sitting at the higher level, from the CHC or above, through this eSanjeevani Ayushman Bharat Health and Wellness Center. So these two are there. One is the doctor to patient OPD kind of thing. Second thing is doctor to doctor. It is doctor from a lower center to doctor to a higher center. So both these are covered under the eSanjeevani. So eSanjeevani is 1 point for you. Now, second one, COVID. What was COVID? COVID is a platform for the digital management of COVID-19 vaccination in India. Then you have, when I talk about COVID, I have to talk about UWIN. UWIN is a digital platform for routine immunization services under UIP. So it's basically to list the beneficiaries and all. We have a digital platform for a routine immunization under the Universal Immunization Program in India. That is the UWIN portal. Then we have Anmol. What is Anmol? Anmol is ANM online. ANM and OL4 online. So it's basically a mobile-based application used by ANMs during their field data entry. Then we have Nikshay and Nikusht. We have already discussed. Nikshay is for the TB portal and Nikusht is for the leprosy portal. We have RCH portal, which helps in tracking the maternal, newborn, child and adolescent health services. Then IDSP. IDSP is Real-Time Integrated Disease Surveillance Program, or Real-Time Disease Surveillance and Outbreak Monitoring in India. Then last one, what is Telemanas? It is a national level mental health program launched in 2022. So these are some of the important digital health initiatives which you should be knowing. Moving on to the next question. Based on current trends of declining birth rate and low stable death rate, India is currently in which stage of the demographic transition? So the question is basically about the demographic cycle or the demographic transition model. We have 5 stages: stage 1, stage 2, 3, 4, and 5. India is currently in which stage? 2, 3, 4, 5. The option which is correct here is stage 3. India is presently in stage 3, which is your late expanding stage. How do you remember this? India, our flag is how many color? Tricolor, 3 color, right? So our Indian flag is tricolor. So we are presently in stage 3. At present, we are in stage 3. Later on, once our country progresses, we'll move on. Okay, that is different. But as of now, remember that India is in stage 3. Mnemonic is, remember our flag, tricolor flag. So stage 3. We'll quickly see the demographic cycle. Due to lack of time, I won't be able to explain the whole thing. We'll see it quickly. So what is the demographic cycle? So basically, every country will pass through. Once you consider the country, every country, once it is developing from pre-industrialized phase to an industrialized, or from the developing phase to a developed country, over the years, it will pass through different stages. That is called as a demographic cycle, starting from the stage 1 to stage 5. And what are the things that determine the which is the stage? Is basically 2 things. One is your birth rate, second one is your death rate. So you have initially, if you see here, the pink graph you see here is the birth rate, the blue graph you see here is the death rate. So once a country is in the pre-industrialized, remember, think about India many years, centuries back. We had no development, nothing. At that era, most of the countries, every country, when it starts, it is in the first stage. That is called as the high stationary. So in this phase, if you see, the birth rate is very high, the death rate is very high. Why? Birth rate, we have no contraceptive, nothing. So the birth rate is very high. Okay. Death rate, we don't have good antibiotics, we don't have vaccines, we don't have good medical facilities. So death rate, people don't live much, don't live long. So death rate is also very high. Obviously, when the death rate is high, also we have a increase in birth rate. So anyway, remember that death and birth rate are very high in the stage 1. Both are high, so you call the stage as high stationary. So this is stage 1 is also called as high stationary. Now, once the country is developing, what will decrease first? What do you think will fall first? Is it the birth rate or the death rate? When you're having an improvement, what will you think as a policy maker? Will I be more concerned about decrease, let's control the population in India, or will I be more concerned about decreasing the death I'll be more concerned with the mortality, right? So I will try to bring up new medicines, new technology, new hospital facilities, everything, so as to decrease the death rate in my country. So that same thing happens in every country. So what will happen? First, once you're progressing, the death rate is going to start decline. You see here, the death rate is going to decline, but birth rate is not affected. It's kind of the same. So this stage is called as the early expanding phase. So stage 2 is early expanding. Okay. And you see the gap here, the gap between birth rate and death rate. This is called as the DG, or the demographic gap. So this gap is highest in stage 2. So stage 2 is death rate is falling, but birth rate is still high. So there's a big gap between the birth and death rate. This stage is called as the early expanding. As the name indicates, the population is going to expand in your stage 2, that is early expanding phase. And the gap is called as the DG. So DG is highest in, that's an MCQ, it's in the early expanding phase. Now, once the country is further progressing, your death rate will fall. Along with that, now we are concerned about the birth rate. Death rate is falling. So many people are there. Population is increasing. We don't have opportunities. We are having scarcity of food, job, everything. Now we are concerned with decreasing the birth rate. Now we come up with family planning services, everything, and birth rate starts falling. So at stage 3, your birth rate also starts falling. Death rate is also falling. So this phase is called as the late expanding phase. So stage 3 is late expanding. Still it's expanding only, but it's decreasing. So birth rate is falling, death rate is also falling. India is currently in stage 3, which is late expanding phase. Afterwards, what happens is, after a point, your both will again come to stationary phase. Birth and death cannot decrease beyond a point. Okay, now it begins low, and again this is called as the low stationary phase. Okay. Now, after the low stationary, you have a stage 5, which is called as a declining phase. What happens is, beyond a point, you cannot decrease the death rate. Okay, so death rate becomes static here. It becomes constant, kind of constant here. From here, death rate is almost the same. But birth rate can fall again. So this phase, in stage 5, this is the only phase where your birth rate is coming below the death rate. So what happens to the population? From the early expanding, late expanding, low stationary, now your population is going to decline. The total population of the country is going to decline in the declining phase. So most of the developed countries, highly developed countries like Germany, Japan, Italy, these are all in the phase 5 or the stage 5, which is declining phase. So examples are, so which are the 5 phases? High stationary, where both are high. Then you have early expanding, late expanding, low stationary, and finally you have a declining phase. India is in phase 3. For phase 4, you can give examples like US, Canada, Australia, and phase 5, it is Germany, Italy. Those are the declining phase. Now, some more points are, what do you mean by demographic gift? See, demographic gift or dividend is your stage 3. Stage 3 is called as the demographic gift or dividend, because in stage C, if you see, it is a late expanding phase. And when you see the population structure, stage 3 mainly composes of the young population. Old age people will be less, but young population will be more, or the working class will be more. Okay, and the dependents, that is the old age people, will be less. So that is actually a stage of opportunities where the country can progress further. So that is why it's called as a demographic gift or dividend. That is stage 3. Stage 2, the stage 2 is the where your demographic gap is highest. This is expanding population is called as a demographic trap. Why? Because the population gets trapped. Population is too much. We have nothing. We are like facing poverty. There is no development in the stage 2. That is demographic gap. Hence, it is also called as demographic trap, because the country is trapped in underdevelopment and poverty in the stage 2. So stage 2 is the demographic trap, and 3 is the gift. So these are the major points about the demographic cycle. So with that, we are moving on. Next question. What do you see here? This is the age-sex pyramid, right? So the age-sex pyramid shown here has a very broad base, yes, and a tapering top. What does the structure indicate about the population? So basically, what is age-sex pyramid? It's looking like 2 histograms kept together, right? So it's called a double histogram also. So basically, it is a image, or it's a graph kind of thing, which shows the sex and age distribution of our population. So you see, this side is showing the male population, this side is the female population, and here you see is the age group. This image is not very clear. Here you have the different age groups of the country, starting from the 0 to 4 age group to the highest age group, whether it is 80 or 70 or whatever. So this side shows the age group, and this shows the the gender distribution of the country. So if a country is having, the broader base, means that means the younger population is more in this particular country. Towards the top, it is the older population. So India currently has this kind of a AIDS experiment where we have more of young population, children and youth more, and the older population are less. So here, the structure here is the option would be option B, that is a young growing population with high fertility. This is what this particular AIDS experiment tells you. So AIDS experiment can tell you many things. One is the age distribution and the sex distribution. Second thing is the symmetry. You see, if the both these histograms, the male and female side, looks symmetric, that means the sex ratio is almost equal, or sex ratio is kind of normal here in this particular image. Then the height of the pyramid, what does it tells you? Height basically tells you the life expectancy of the country. So if a country has, say, people die around 50 years, the pyramid won't be this tall. It will be somewhere here. Okay. It will be somewhere here if the life expectancy was 50. Suppose the people in this country die at around 95 years of age. So your pyramid will be more taller because people die at 95 years of age only. So the height of the pyramid basically tells you gives you an idea about the life expectancy of the country. So moving on to the next question. Sorry. So next question is about the fertility indicators. We have different fertility indicators. It's a very important topic for INICET, INICET exams as well as your medpg exam. But due to lack of time, I'm not explaining everything. Please go and study the the basic notes for all the indicators of fertility. So this question is about the NRR, or net reproduction rate. So NRR is the most sophisticated measure of fertility. Yes, that is correct. What key factor does NRR account for that GRR does not? So we are talking about NRR and GRR. What is special about NRR with respect to GRR? Sex ratio at birth, number of marriages, mortality among females from birth to reproductive age, use of contraception. See, the answer here is option C, that is mortality. See, the only indicator, we have different fertility indicators, I told you. Only indicator which takes into consideration mortality is NRR, or net reproduction rate. What are the different indicators you know about? We have total fertility rate, or TFR. Then you have GRR, NRR. We have age-specific fertility rate, AGFR and all that. I'm not going into that. You have the general fertility rate, which is GFR. Okay, this is gross reproduction rate and net reproduction rate. That is GRR and NRR. So basically, TRR gives you the average number of children per woman. So how many children a woman has? Average. This is for a country we're telling. So it's not very easy to calculate. It's actually kind of your average of all the age-specific fertility rates and all that. But in simple words, if I tell you, TFR, or total fertility rate, is the average number of children per woman. So if I have 2 kids, my TFR is 2, just like that. Okay. Now, GRR and NRR tells you the number of daughters. When I talked about TFR, it's the average number of children, whether it is son or daughter. Okay. But GRR and NRR talk specifically about, not about son, but about the average number of daughters. You remember R, daughter has an R, right? So daughter has an R. So GRR and NRR, they're talking about daughters. So GRR is basically the average number of daughters per woman, and NRR is average number of daughters per woman only, GRR itself, but considering mortality. So it's average number of daughters per woman who survive, okay, or who survive that age group. So that is NRR. So NRR and GRR are almost the same. They consider the average number of women born to, average number of daughters born to a woman. Why? Because daughters are the ones who are going to, give birth to the next generation. So average number of daughters born to a woman is GRR and NRR, but GRR does not consider mortality, whereas your NRR takes into consideration the mortality also, whether these girls survive up to the adulthood. That is also being included in your NRR. Okay. So what is the replacement population level? So replacement level of fertility is NRR equal to 1. If NRR is equal to 1, that is called as the replacement level of fertility. And TFR, if NRR is 1, TFR will be around 2.1. So this is the replacement level of fertility, meaning your population is going to be stable. Replace NRR equal to 1 means if I'm a woman, I give birth to 1 daughter only. So I'm just getting replaced. My daughter is kind of replacing me. That is NRR equal to 1. So again, she will again give birth to 1 more daughter. So it's like one woman getting replaced by another woman. That is replacement level of fertility. In that case, your population is not going to explode. It will kind of remain in a stable position. So that is replacement level of fertility. Now we'll move on to the next question. The midday meal scheme is mainly aimed to. What is this midday meal scheme? The name has been renamed also. So midday meal scheme is mainly aimed to option A, reduce IMR, option B, improve school attendance, option C, prevent occupational diseases, option D is reduce NCDs. I hope all of you know that midday meal scheme is what? Giving free food, free midday meal, free lunch to students studying in government schools till till class 8th standard. Okay, till 8th standard in government schools, the children or the students kids get free midday meal. And the midday meal scheme was not the main aim of this scheme was not to improve nutrition but to improve school attendance. Okay, because if children are getting food from school, at least the parents who are facing it very difficult to feed the children because of poverty, these children come to school. At least for that meal they come to school. So basically, this scheme was introduced to improve the school attendance. Nutrition comes only as a secondary. Improving nutrition comes only as a secondary aim for that. Main aim was to improve the school attendance. Now, what's the new name of midday meal scheme? This has been changed. In PSM, there's an issue with PSM. We keep on changing all the names of the programs, names of the institutions, as well as guidelines also change, numbers change. You have to be updated when you are facing your entrance exam for PSM. Okay, so midday meal scheme has no longer has this name. Now it is named as PM Poshan Scheme. So Pradhan Mantri Poshan Scheme is the new name for midday meal scheme. What's the logo? You see school kids sitting in a round with their lunchbox. That is the logo for midday meal scheme. Now the name is PM Poshan. It's not midday meal scheme. PM Poshan is Pradhan Mantri Poshan Shakti Nirman. This is actually the new full name for this particular scheme. So I told you this is mainly to improve school attendance, retention in school as well as nutritional status. The primary aim is school attendance. It covers children from class 1 to 8 standard. Next question. Primary agency of socialization. So which is the primary? This is a question from sociology. Primary agency of socialization is school, family, media, peer group. Very simple question. Just tweaked and told with some jargon words. That's all. So from where do you learn everything? Where do you learn your language, behavior, your character, your value, everything? The first institute which teaches you all this is family, right? So option B is the correct answer here. Primary agent of socialization, family. School becomes your secondary socialization. After family, a child learns the rest of the things about the character, the values, culture, everything from schools. So first, primary agency of socialization is your family, and your secondary agency is schools. Your peer group are actually, they influence your behavior during adolescence, and the media is also an indirect or it's a social influence. But when asked the primary agency, it is always the family. Next question. What is family cycle? So family, we have, this is taken from Park only. We have different phases of family cycle starting from the formation, extension, complete extension, contraction, completed contraction, dissolution. These are the 6 phases in a family cycle. This is also an important question. We learn the family cycle with the help of Varnamairam. Okay, ready with me? So let's learn family cycle. First thing, first step is the formation. I hope the images are clear to you. So formation is a phase where it starts from marriage, formation of a family. In the first step in the family cycle is the formation of a family. Family has to be formed. That's the first thing. Formation involves the beginning of the phases from marriage to birth of the first child. So that is the first phase of family cycle, formation. That is from marriage to birth of the first child. Second step is your extension. Extension is birth of first child to the birth of the last child. That's the family is complete. That phase is called as extension. So you have formation, then you have extension. Third phase is complete extension. Third phase is complete extension. Complete extension expands from the birth of the second child, that's the family is complete, to the first child leaving home. The first child is leaving home, say for job or got married and leaving home, whatever it is, first child leaving home, that forms the complete extension of the family. So you have formation, that is marriage. Then up to the birth of first child is formation. Then you have extension, that is from first child to the birth of the second child or the whichever is the last child. Okay. Then once the family is complete to the first child, for son or daughter, whoever it is, leaving home for any reason, that becomes complete extension. So we have talked about 3 stages. Now the family starts to, from formation, it has extended. Now it starts to contract and finally it dissolves. So the next stage is the fourth stage is contraction. Contraction is when the first child leaves home to the last child leave home. So now the first child has left. Now the last child is also leaving the home and the parents are alone. This stage is called as the contraction. This is also called as the, it's not a term in your textbook, but we have something called as the empty nest syndrome. What do you mean by empty nest? Nest is empty. All the kids have flown away. That is the empty nest syndrome. So the children living abroad or living away from the parents, maybe for education, for marriage, or whatever reason, and the oldest parents are alone. That is called as the empty nest syndrome. So that is contraction. So now you have something called as the fifth stage is completed contraction. So completed contraction is when the last child has left the home of the parents to the first spouse dies. So you had a husband and wife starting. Here now the first spouse dies. That is called as completed contraction. And finally, you have the dissolution. When the surviving spouse or the husband or wife, whoever is left, he or she also dies, the family is dissolved. That is called as the complete dissolution. So these are the different stages in a family cycle. Without Varnamairam, we'll learn from Park. Okay, but remember the images that I've shown you earlier. So you have formation, you have extension, you have complete extension, contraction, completed contraction, and finally dissolution. So these are the phases of a family cycle. Now we'll move on to the next question. Oh, this is a question on economic evaluation. So public health researcher compares to hypertension intervention and estimates the additional cost required to achieve an incremental improvement in health outcomes between them. So basically, he's comparing the cost with outcome is the improvement in health outcomes. What type of economic evaluation is being used? So we have four types of economic evaluation, which are there. We have cost analysis, we have cost minimization or cost analysis, you have cost benefit analysis, you have cost utility analysis, and finally cost effectiveness analysis. So these are the four types of economic evaluation. So economic evaluation is basically, see, when you have health resources, when you're allocating, say, money or resources for particular programs, we have to see the output, right? So I have 1 lakh rupees with me. Should I invest this in TB program or leprosy program? Only I have 1 lakh rupees. I cannot divide and give. I'll have to give in one program, majorly, because also it's only 1 lakh. It's a very small amount when you're comparing a big program and a big population. So that I have to decide where I get most effect when I'm spending this money. For that, we need something called as economic evaluation. We have different techniques of economic evaluation. Your options you got here, these are different techniques. So all the techniques, whether it is cost analysis, cost benefit analysis, cost effectiveness, everywhere the input is the cost. Basically, the input is whatever you are inputting is the cost, and the outcome differs. So based on what you are measuring as the outcome, these are termed into different types of economic evaluation. So if I'm measuring the outcome also in terms of money, it becomes cost benefit analysis. But if I'm measuring the outcome in terms of quality, it becomes cost utility analysis. And if I'm measuring the outcome in terms of health outcome, say the number of people improved or the number of lesser number of deaths avoided, something like that, that's a health outcome. It becomes a cost effectiveness analysis. And in simple cost analysis, you're just comparing the cost. We are not measuring the outcome per se. So these are different cost analysis. So here the option is the improvement in health outcome is being measured. So here the answer is cost effectiveness analysis. And this is the most commonly used economic evaluation technique as far as health sector is concerned. Okay. Same thing only. Cost effectiveness, you are measuring the cost as input and the result is the outcome. Cost benefit analysis, even the outcome you are measuring is in monetary terms. But it is difficult because how can you, it's actually difficult on how to, monetize your outcome. How can you measure how can you put a money on the death averted? How much will I allocate for death averted? That is difficult, no, but in certain situations, we cannot do that. But you should know that there is a cost benefit analysis where the outcome is also measured in terms of money. Cost utility analysis measures outcomes in terms of quality. And the cost effectiveness is the most commonly used one in health, public health. And here the outcome is measured in terms of health outcomes. So it can be your life years saved, or it can be, the cases prevented, or, BP reduced, whatever is the health outcome that can be used in the health cost effectiveness analysis. Moving on to the next question. So a 3-year-old child in a remote rural area presents with high-grade fever and chills due to limited laboratory, presents with high-grade fever and chills. What are we talking about? This is malaria, okay. Due to limited laboratory infrastructure and lack of microscopic facilities, the healthcare worker uses a bedside test that detects specific Plasmodium antigens and provides result within minutes. So you have a 3-year-old child with fever, chills, and all that, and it's in a rural area, so you don't have the microscope or anything. So health workers goes with a bedside test and detects that the child is having specific Plasmodium antigens, so which is a test they are using. Puffy goat examination, peripheral thin smear microscopy, peripheral thick smear microscopy, or rapid antigen detection test. The answer is actually very quite simple. It is rapid antigen detection test. The bedside test which you use is usually a CAR test. Rapid CAR test, you take 1 or 2 drop of blood, put it on that, and it will show you lines. Just like the urine pregnancy test, you have CAR test for detecting Plasmodium falciparum as well as bivalent. So we have bivalent as well as univalent CAR test now. So the answer here is rapid antigen detection test targeting HRP2. HRP2 is nothing but histidine-rich protein 2. It is an antigen specific to Plasmodium falciparum. So that is actually being detected. That was about malaria. So what are the tests for malaria? Tests for malaria. First one is peripheral smear microscopy. This is always the investigation of choice. Malaria, the microscopic test that is the investigation of choice is always peripheral smear. You can make 2 types of smear, right? What is the thick smear? One is thick and another one is a thin smear. Thick smear is actually for screening. That is, you can see whether the Plasmodium is present or not. To detect whether there is malaria or not, that you use the thick smear. And thin smear is a thin layer you make. And this is basically to identify species, whether it is Plasmodium vivax, falciparum. Each one has different morphology, you know it. So based on that, you can identify based from the thin smear. So to identify the species, you have thin smear. Then you have RDT, which is a rapid diagnostic test. It fast, very easy to perform, and you get results within a few minutes. So 15 to 20 minutes hardly you get the results. That is rapid antigen detection test. So as per the investigation of choice, it's always sputum, not sputum, peripheral smear microscopy. But like in our example where we don't have microscopy, to do a peripheral smear microscopy, you have to have a microscopy. You need a lab technician there, and you need somebody who can understand whether there is Plasmodium in there. So we have certain logistic issues. So that might not be available in certain rural areas. So there you can go for a rapid diagnostic test. That's also perfectly fine as per the program. Image-based questions. This is a thick smear. This is a thin smear. What is this? This is the one our question was asking about. That is your rapid antigen detection test. The logo of NBBDCP, National Vector-Borne Disease Control Program, which are the 6 vector-borne diseases under the program: malaria, Kala-Azar, dengue, chikungunya, JE, and lymphatic filariasis. These are the 6 diseases under your NBBDCP. Quickly, we'll see the malaria treatment. So, malaria treatment. So, it depends on the species. If it's vivax, we have another treatment. For falciparum, you have something else. And you have mixed malaria, where you have vivax plus falciparum. So, what's the treatment for vivax? Vivax, you give chloroquine, total how much? 25 mg per kg distributed over 3 days, right? Chloroquine, 25 mg per kg distributed over 3 days plus primaquine, 0.25 mg per kg per day for 14 days. So, chloroquine plus primaquine is the treatment for vivax malaria. For falciparum, what do you give? Falciparum, you have ACT for 3 days and single dose primaquine on day 2. You give 75.75 mg per kg, single dose primaquine on day 2 and ACT for 3 days. That is for Plasmodium falciparum. And for mixed, this mixed treatment, okay, in mixed, you have to give both. So you give ACT for 3 days plus primaquine for 14 days. So this part from here I'm taking and this part from here I'm taking. When I mix it, I get the mixed treatment. So that is ACT for 3 days and primaquine for 14 days is the mixed management or treatment regimen for the mixed malaria. That means it has falciparum and vivax positive. One more point, ACT for 3 days I told you. Which ACT are you giving? It is based on the location, right? So if the person is from a northeastern state, you give ACT AL. AL is artemether and lumefantrine. And if from all other states or rest of India, you give ACT SP, sulfadoxine and pyrimethamine. So if it's a northeastern state, you go for ACT AL. If it's the any other state other than Northeast, you go for ACT SP. So that was in broad about the malaria treatment. What about the prophylaxis? Somebody going to a malaria prone area, if it's the duration of travel is less than 6 weeks, you give D, doxycycline. If the duration is more than 6 weeks, you give M, mefloquine. So less than 6 weeks, think about Delhi. To go to Delhi, you need think like that. It's just a mnemonic, okay? Think about Delhi, D for Delhi, D for doxycycline. Less than 6 weeks, you go to a nearby place. More than 6 weeks, you need a bigger place. M for Malaysia, you can think. Okay, mefloquine for Malaysia. Going to Malaysia, you're spending there like going to stay there for more than 6 weeks, enjoy and come back. So doxy D or Delhi for less than 6 weeks travel, more than 6 weeks travel, Malaysia or mefloquine. This is the the prophylaxis that you have to give. Last question from malaria is pregnancy. Malaria in pregnancy. How do you give? Which is a drug contraindicated in pregnancy? Out of the drugs that we've discussed for malaria, primaquine. Primaquine should not be given to a pregnant lady, to an infant, and also to somebody who has DASH deficiency. Which one? G6PD deficiency. Don't give primaquine. So if a patient is pregnant and she gets malaria, what happens? What will you give? In that case, in first trimester, if she comes to you in first trimester, treatment of choice is quinine. Quinine is given 10 mg per kg thrice daily for 7 days. Any other trimester, whether it is second or third trimester, you can give the area-specific ACT. You don't give chloroquine and primaquine. First trimester, go for quinine. Second or third trimester, you give area-specific ACT. Whether it is Northeast or the other state, depending on that, you decide to give ACT AL or ACT SP. That's about malaria. Moving on to the next question. 12-year-old child presents with fever, anorexia, jaundice. Okay, now you have the symptoms. Multiple similar cases are reported in the same locality following contamination of the community water supply. You're talking about a waterborne outbreak, right? Okay. Now, which of the following viruses is the most likely cause? Options are HPV, hepatitis B, hepatitis C, hepatitis D, and hepatitis A. So, which is the most common cause of waterborne outbreaks, especially in children? It is hepatitis A. Answer is HIV or hepatitis A is the answer. Here, the clues in the question that tells you that this is hepatitis A. Symptoms: fever, anorexia, jaundice is pointing out towards hepatitis. Jaundice itself is pointing towards hepatitis. And since this is through fecal-oral route, that is why it is because of contaminated water supply means fecal-oral route. So that is again pointing towards hepatitis A. So hepatitis A has what transmission? Fecal-oral transmission. What about the other options here? The hepatitis B is through blood or sexual or perinatal. HCV is also bloodborne only. And HDV, hepatitis C usually coexists with your hepatitis B infection. Okay, that was about the viral hepatitis. HIV is the most common cause of waterborne hepatitis and outbreaks in children. Next question. 2-year-old child brought with profuse watery diarrhea and vomiting for 2 days. So child has diarrhea, vomiting. Examination, the child is lethargic with sunken eyes, decreased skin turgor, delayed capillary refill. There's dehydration, right? There is no blood or mucus in the stool. There is no blood or mucus in the stool. So the basically child has profuse watery diarrhea and vomiting. Multiple similar cases have been reported in the community during winter. Which of the following is the most likely etiological agent? Options: E. coli, Shigella, rotavirus, and Vibrio cholera. Which is the answer here? See, if it's E. coli, what will you get? E. coli usually has it's called traveler's diarrhea, right? And it has a variable presentation based on the type of E. coli. It's not a typical presentation that they have told you. Then your Shigella usually is notorious for bloody diarrhea. You have blood and mucus in the stool, that is Shigella. And you have tenesmus, okay? That is painful defecation. That's all with Shigella. Now, Vibrio cholerae, the classic rice water stool. Now we are left with the option. This is the correct answer. That is option C, rotavirus. So rotavirus is the leading cause of severe dehydrating diarrhea in under 5 children. And all the symptoms told here are susceptible or are suggestive of rotavirus diarrhea. Okay. Another question about the vaccine. We have vaccine for rotavirus. How will you give? It's a drop. It's an oral vaccine, rotavirus vaccine. 5 drops you give. Then what else can I? Yeah. Rotavirus is, does it follow open vial policy or not? See, rotavirus is a live vaccine and it follows open vial policy. That means, what is open vial policy? You open a vial of a vaccine, you can reuse it within 28 days. Okay, you open a vial, you don't no need to throw the rest of the vaccine. If it's there, you can, if it is maintained under proper cold chain and everything, you can reuse the vaccine within first 28 days of opening it. That is called open vial policy. This prevents vaccine wastage to a lot of extent, and rotavirus is obeying open vial policy. Meaning, if you open rotavirus, you can use it completely within 28 days. After 28 days, you have to discard. Okay. Confusion that comes is, ma'am, rotavirus is a live vaccine. Why is it following open vial? Nothing like that. Okay. There is no live and kill vaccine, this thing for open vial policy. Basically, the vaccines which needs to be reconstituted cannot be used later on. Okay. Like your MR, your measles vaccine, your BCG vaccine, the live JE vaccine, which we had, these things need to be reconstituted. Once you reconstitute the vaccine, you have to throw it away. After the session, you cannot keep it for 28 days or not even 1 day, you cannot keep it. Okay, that has to be thrown away within 4 hours and all that. Those are reconstituted live vaccines. They do not follow open vial policy. Other than that, your rotavirus doesn't need any reconstitution. It follows open vial policy. I hope that is clear to you. One more question. Most common, or not common, the symptom, the side effect which is associated with rota is intussusception. So if a child has intussusception, please don't give rotavirus. You refrain from giving the rotavirus to a child with intussusception. Okay, moving on to the next question. Socially acquired learned behavior is known as custom, culture, socialization, and more. What is a socially acquired? A socially acquired learned behavior is culture. Okay. What are the others? Custom is a traditional practice. So traditional social practice becomes custom. Culture is what? It's a learned behavior is culture, which you learn from the society. That becomes part of your culture. That is culture. Socialization means, process of learning the culture. I have to socialize so that I learn the culture. That is socialization. Mores are some of the strong moral norms that are existing in the society. That is mores. So here the option is option B, culture. Now, one more thing, commonly asked favorite question is, what do you mean by acculturation? Acculturation means it's a cultural change that occurs due to coming in contact with another different culture, or it is adoption of another culture's traits. That is what you call as acculturation. For example, we Indians adopting Western food habits or Western dressing style. That is an example for acculturation. Okay, I'll move on to the next question. So, under the National Program for Control of Blindness and Visual Impairment, cataract surgery services are organized to ensure safety and quality, which of the following practices is not recommended. Identifying patients and referring them to base hospital is one of the recommended things. Promoting small incision cataract surgery is also recommended. Transporting patients to fixed facility surgical centers is what you do in the program. Conducting surgeries in temporary makeshift operation theaters in rural areas is absolutely wrong. You cannot conduct a cataract surgery in a temporary, makeshift operation theater. No, that will create a lot of sepsis and issues. So according to the program, you have to identify people with cataract who need surgery, refer them or take them to a fixed facility where you have surgery facilities and then operate them there. Okay. And usually we promote small incision cataract surgeries. So this is the logo for National Program for Control of Blindness and Visual Impairment. So it was NPCB, National Program for Control of Blindness. Now it has been renamed to NPCBVA. That means we have added a visual impairment component also along with this program. Moving on to the next question. A man presents with fever and chill 2 weeks after a louse bite. There was a maculopapular rash in the trunk which spread peripherally. The cause of this infection can be. Options are strep typhus, endemic typhus, Rickettsial pox, epidemic typhus. So we are asked the questions about the Rickettsial disease vectors. This is an area which students tend to skip because it's kind of confusing and a lot of Rickettsial diseases are there. But my dear friends, questions do come at this last minute. If you cannot study, it's okay. But if you have already revised, please do revise it once more because this is actually an important area. Okay, you can get questions from Rickettsial disease also. So we'll see here with a mnemonic. So you have a man with fever, chills, and the main clue here is the vector, the louse bite has been told here. Okay, patient gets maculopapular rash and all that. And what is the infection? So you have scrub typhus, endemic typhus, rickettsial pox, and epidemic typhus. See, the major vectors for rickettsial diseases can be louse, it can be flea, it can be tick, and it can be mite. Okay. Now, based on the vector, we learned the names of the rickettsial diseases. So, louse spreads epidemic typhus. Flea gives you what? Endemic typhus. Tick spreads Rocky Mountain spotted fever, and your mite spreads scrub typhus as well as your rickettsial pox. Okay, so louse gives epidemic typhus, flea for endemic typhus, tick, Rocky Mountain spotted fever, and mite, scrub typhus, and rickettsial pox. Got your answer, right? They have asked you louse, and which is the the disease I've told you. Louse is for epidemic typhus. So option D is the correct answer. Now, how do you remember this? We have a mnemonic. Let Fen is the name of a boy. Try PSM. Why should you have all the fun? Let Fen also try PSM. Okay. So let Fen try PSM is the mnemonic I have. This is not made by me. This is an existing mnemonic which I have studied in my MBBS times. We would have heard it. It's actually a good mnemonic. Okay. We'll see let Fen try PSM. So let is louse epidemic typhus. Okay. So LET. This is the let in my mnemonic. So louse gives epidemic typhus. Coming to the next word, Fen. Flea. Fen. EN is for endemic typhus. EN. Endemic typhus starts with EN, right? So FEN Fen is flea for endemic typhus. Then you have try. T is for tick and RY is for Rocky. Rocky Mountain spotted fever. So you get try, right? And PSM is kind of difficult. It's ulta. Everything is, in your mind, it's all clubbed up ulta. So this mnemonic is also ulta for you, for PSM. Okay. So this is M, this is S, and this is P. Pox, P. Scrub typhus, S, and M. You read it like this. Read it in the ulta way. So you get PSM, right? So let Fen try PSM is the mnemonic. It's given. Okay, it's given here separately also in the PDF. If you want, it's there. You can learn it from there. So if it's louse, epidemic typhus, Fen, flea, endemic typhus, tick, Rocky Mountain, that is try, and PSM is pox. P, it should be P, okay? Pox, typhus, and mite. So this is your mnemonic for rickettsial disease vectors. Now, this is the whole classification of rickettsial diseases. You have typhus diseases, spotted fever, and others. Remember, in others, you have Q fever. Okay, Q fever is caused by Coxiella burnetii. That's almost everything is by Rickettsial. Okay, scrub typhus is by Orientia, Sutsuga Misri. So, if you can remember, it's well and good. But at least try to remember this mnemonic. It might save you many times. Okay, moving on to the next question. Two radiologists independently interpret 100 chest X-rays. The agreement between them yields a kappa value of 0.71. How is this level of agreement best interpreted? It's a good agreement, poor agreement, very poor agreement, intermediate agreement. So this basically is a good agreement. What do you mean by kappa statistics? Actually, this is a previous year INICET question. Okay. So kappa statistics is a statistical method or a technique which tells you the level of agreement between two independent researchers. Say, like in this example, you have to read X-ray. So if two people are reading the X-ray, same X-ray, if I am reading and if you are reading, I might interpret in a different way from you. Some of the things will be similar, like if it's obvious things and all, both of us will be having the similar kind of reading, but still we will differ in certain things. So how much is that agreement between what I read and between what you read? That is being measured by kappa statistics. The thing is, for certain things, we have the chance just purely due to random error, just due to chance. Sometimes we both will have the same agreement, right? We will have the same findings. That has to be eliminated because whatever happened due to chance, you cannot take it into account. After eliminating that, how much is the agreement between you and me or between two researchers is what kappa statistics is all about. So they have different values for kappa from 0 to 1, from 0 to 100. And if it is more than 70%, 60 to 80 is almost good or substantial agreement, and 80 to 1 is almost perfect or good agreement. So kappa statistics is basically to measure the agreement between observers beyond chance. That is why we use kappa statistics. And we have a formula for kappa, that is observed agreement minus expected agreement by chance divided by 1 minus expected agreement. This is the formula for kappa statistics. I'm moving on to the next question. Okay, so a clinician is assessing stages of behavior change in different individuals attempting lifestyle modification. Which of the following is correctly matched? A smoker thinking about quitting is contemplation stage. A person unaware of benefits of exercise is in pre-contemplation stage. A person abstinent from smoking for 1 year is in maintenance stage, and an obese individual unwilling to change due to family history is action. So what are we talking about? This is a behavior change model. We have two behavioral change models to learn. One is the trans theoretical model. Second one is the health belief model. Basically, it's like when a patient comes with diabetes, you give the medicines, everything, but will medicines alone work? No, you have to advise them some lifestyle modification, tell them to exercise or eat healthy, things like that. That lifestyle modification, do people take it? See, it's easier to take the drug than do a behavioral change. Okay. So we have certain theories on to how do people actually react to your lifestyle modification. Now, how is this behavioral change happening? For that, we have two models. One is your trans theoretical model. Under that, we have different stages like pre-contemplation, contemplation, maintenance, like that. Each stage has a meaning. This question is all about that. Okay. And we have a health belief model. I'm not going to explain about health belief model here. We don't have time. Quickly, we'll see the trans theoretical model. So, trans theoretical model basically has these phases. It has a pre-contemplation, contemplation, preparation, action, maintenance, and relapse phase. So, what is pre-contemplation stage? Pre-contemplation is when a person is not aware, uninformed, and there is no intention to change. For example, think that okay, I'm facing obesity. Okay, my BMI is too high. I am obese, and at this particular point, I went to a doctor with some health effects, and the doctor told me, "See, you are obese. You have to do some exercise or something, and you have to reduce your weight." And I'm like, no, doctor, obesity runs in my family. My father is obese, my mother is obese, my grandmother is obese, everybody is obese. There is no point in exercising. I will be obese even if I exercise. So it's kind of I am not aware, or I'm even though I'm aware, I have no intention to change. I'm not going to do any exercise or nor I'm going to improve my diet. That stage is called pre-contemplation stage. That is, you are having no intention to change at all. That is pre-contemplation stage. Second one is contemplation phase. That is, you are thinking about change. Like you are aware of problem exists and you're thinking about changing. For example, let me take the same example. I'm obese, I told you. So I'm trying to climb up stairs, and even after climb up one set of stairs, I'm like having shortness of breath. I'm not able to climb up even that stairs. So now I start thinking, see, maybe it is because of the obesity. I should do something. Maybe I should exercise and I should, come to a healthy way. So I'm thinking about changing. That phase is called as the contemplation stage. Okay. Now, next one is preparation phase, where I'm intending to take action. I have not started to take action, but I'm doing something so that I'll take action. For example, I go buy some running shoes and jersey and everything. I'm like, from tomorrow I'm going to go for running every day morning. So I'm doing something. I'm having some intention to take an action. That becomes your preparation phase. Now, action is when you actually do. Action is when you actually act. You make modification in the behavior. I start tomorrow morning. From morning, I go for jogging. I'm doing an action. That becomes the action phase. Maintenance is a difficult phase for everyone, each one of us also. Now I've made modifications, but I have to maintain this. I run for 2 days, I stop. I have failed the maintenance phase. But if I'm maintaining this momentum, I'm maintaining this running, just like you're maintaining your studies, that is the maintenance phase, not losing the hope and everything, not losing confidence. Be confident and keep on being in the maintenance phase, right? That's maintenance. Now, finally, we have the termination phase. That is like uh, I'm having a sustained behavioral change. Like, for example, I started jogging, and for the last 1 year, every day I'm jogging. For at least 5 days a week, I'm jogging, or I'm going to the gym and I'm maintaining it. That becomes a termination state. So, these are the different phases in the trans theoretical model. Okay. In this particular example, what was wrong was option D. An obese individual unwilling to change the family history is not action. That is the pre-contemplation phase where I am not willing to change my behavior. The other model you have is the health belief model. I'm not going to explain about this because we don't have much time here. I have more questions to discuss with you. So we'll move on to the next question. Question number 26. A 26-year-old woman using injectable contraception presents 14 days after missing her scheduled dose. So you have a woman using what? Injectable contraception. So she presents after 2 weeks after missing her dose. She reports no history suggestive of pregnancy and has been compliant with the previous doses. So this is the first time she's losing or missing her dose. Okay, other than that, she doesn't report any symptoms of pregnancy also. What is the most appropriate step? So here they're talking about DIMPA. What is DIMPA? DIMPA is the injectable contraceptive we have. It is dipod progesterone acetate. So DIMPA injection. And what do you do when there is a delay from the scheduled date? See, so if a lady who's taking DIMPA injection is injectable contraceptive, which has to be taken once in every 3 months. So every 3 months you take one injection, you have protection from unwanted pregnancy. So after 3 months, next day you have to come and get the injection again. So it's like every 3 months, one shot has to be taken. Suppose somebody misses the dose and comes to you within 7 days. Okay, I was just late by say 6 days. So within 7 days, a person comes. You don't have to need any additional contraception. Just give the DIMPA dose. No need of any additional contraception because within ±7 is okay. It's fine. The patient is still protected. Okay. So if she comes after 7 days, you give the injection, you give DIMPA, plus you ask her to use some backup, maybe some barrier method or something for 7 days. Okay. If she comes 15 days, more than 15 days late, if the person is coming, first thing you have to rule out pregnancy. Now she's late for 15 days, more than 15 days, you have to rule out pregnancy. Here in your question, she is reported to you on the 14th day. It's not more than 15 days. So here, option C would be the correct answer. You administer DIMPA and advise additional contraception for 7 days. Okay. Quickly, about DIMPA. What is Antara? Antara is in the program, DIMPA injection, dipod progesterone acetate is given under the name of Antara. So this is 150 mg per ml, one injection IM given once in every 3 months. Okay. What is this? There is something new. This is something new under the program. This is called as the Sayana press. See, Sayana press is nothing but DIMPA injection only, but this is subcutaneous. The Antara, the DIMPA Antara that we are talking about is actually DMPA IM injection. Okay. The Sayana press is subcutaneous DIMPA injection. Content, there's a slight difference, but the thing is it's subcutaneously given. So it can be self-administered. To take the Antara or the IM DIMPA injection, you need a doctor or a nurse. She has to give you the injection. Now the program has introduced a subcutaneous or a newer form of DIMPA, that is Sayana press. That's a subcutaneous injection which can even be administered by the women alone. So it can be given in the home-based or a community-based setting also, subcutaneous. So you don't need to go to the hospital. You can get it done it by yourself. Okay, that is DIMPA and Antara. This is the basic difference. Old one, that is your Antara. DIMPA IM 150 mg. Sayana press is DIMPA subcutaneous 104 mg. Antara, since it's IM injection, it has to be given by a doctor. It is clinic dependent. But the other one can be given by ANM or even ASHA or even self. The woman herself can go get the medicine and give the subcutaneous injection. Okay. So that is community or home based. So that's again a new update in your family planning chapter. Moving on to the next question. A patient with advanced incurable malignancies enrolled in a palliative care program. Care support focuses on symptom relief and psychosocial support, which is the best principle of this particular approach. So you're talking about a palliative care program. Okay. Somebody with an incurable malignancy, the final resort is palliative care. So what is this? What's the principle of palliative care? Is it focus on disease eradication? Of course, no. About interventions that may prolong life? No. Withhold active medical care? No. It's basically you are trying to improve the quality of life of the patient who is in the last stage of cancer or any other incurable disease. Palliative care is kind of a supportive care so that the patient can die with dignity. Okay, he or she can die with dignity, and whatever years is left in his or her life, let him live with a good quality of life. How much quality you can improve, that much you try. So that is what this palliative care is all about. We have a program for palliative care. That is the National Program for Palliative Care, NPPC, and just two MCQs here. The home-based palliative care. The home-based palliative care, or this particular state model, is very famous in palliative care. It was first introduced by which state? I am proud to say that it is my state. It is Kerala. Okay, so home-based palliative care was first introduced in Kerala, and Kerala is considered as a model state for community-based palliative care in India. Okay, so which is the model state for community-based care, palliative care in India? It is God's own country, Kerala. Now we have a mnemonic here about palliative care. You can remember Kerala itself. So K, it is basically palliative care is providing kind support, end of life dignity, relief from pain, at home care, local volunteers, and accessible to all. These are all the features of palliative care or the principles of palliative care. Okay. So community-based palliative care, best model is Kerala state model. Okay, we'll move on. Next question, 24-year-old woman presents to the outpatient department seeking contraception. She has regular menstrual period and no history suggestive of pregnancy. She prefers a long-acting reversible method and opts for an IUD. What is the most appropriate time for insertion of this IUD to ensure minimal risk of undetected pregnancy? So, person with a lady comes to you for contraception with IUD. When will you insert IUD? That's a simple question here. Do you give it immediately postpartum, within 48 hours of delivery, within 7 days of onset of menstruation, or within 7 days of next menstrual cycle? When they are asking you when is the most appropriate time of insertion of IUD to minimize the risk of undetected pregnancy. When can you minimize the risk of undetected pregnancy? Best answer would be within 7 days of onset of menstruation, right? So this is the best period as per this question for IUD insertion. Why? Because see, when you take that within 7 days from the start of menstruation, the cervix is, the slightly dilated, then you can actually insert this IUD with lesser discomfort, as well as pregnancy is least likely in that particular period within 7 days of onset of menstruation. That's why we prefer that particular period for IUD insertion. IUD is again a favorite examiner area. So different IUDs I've given you the image. Lipis lupus there, copper T 380A, multi-load 376, Marina. These are all image-based questions. You can get an image and you will be asked to identify the type of, not just IUD, any contraceptive can come as an image-based question. So what are the types of IUD? We have first generation IUDs. Broadly, we have first generation IUDs, which are the inert IUDs. Example, Lipis loop. Then you have second generation IUDs or the copper bearing IUDs, your copper T, 380, your multi-load, everything comes under this copper IUDs, second generation. Finally, you have the third generation or hormone releasing IUDs, Mirena. Yes, then LNG, IUS. These are all examples for, hormone releasing IUDs. Now, one more question is, can IUD be used as an emergency contraception? Yes, it's actually one of the best emergency contraceptive method. It's better than your, IPL and all that. But it has to be inserted within first 5 days of unprotected intercourse, as well as to insert an IUD, you need the help of a nurse or a doctor, right? So it's a clinic dependent. That's why the compliance is not that much, because they have to, the couple, they need to go to the hospital. But other than that, this is the best method for emergency contraception. It is not copper, it's not your IPL, it's actually IUD. Okay. And one contraindication for IUD insertion, first thing you have to rule out active pregnancy, definitely is active PID. If a person is having pelvic inflammatory disease, please don't insert IUD in that particular lady. So active PID is an absolute contraindication for active PID is an absolute contraindication for insertion of your IUD. Moving on to the next question. 38-year-old woman undergoing routine screening is found to have high-grade squamous intraepithelial lesions on cytology. So it's a cancer. Further evaluation reveals persistent infection with a high-risk viral genotype known to promote malignant transformation by inactivating tumor suppressor proteins. Which of the following HPV types is most commonly associated with this condition? Simple question. Which is the HPV type that leads to cancers, or which is high-risk oncogenic types of HPV virus? That is the question. But INICET examiners, they have a tendency to write paragraphs for a simple question. Okay, just to terrorize you, to confuse you, to make you anxious. But you practice well, you sit calmly, you have learned everything. Be pleasant, be calm, and think and do the question. It's all actually very basic, simple questions, just tweaked and twisted in a different way. Okay. So tell me which is the most common HPV associated with cancers? 1618, right? Simple question, but just shown in a very big, confusing way. So HPV 1618 is associated with CA cervix. So that is the high risk oncogenic type. 611 is associated with what? Genital warts. See, 31, 33 are also high risk, but they are less common. and 42, 44 are low risk type of HPV. Update alert. What is this? Cervavac HPV vaccine. Have you heard this? Recently, we had in our country, we had an HPV vaccination drive where Cervavac vaccine, the HPV vaccine Cervavac. Why Cervavac? Because it is cheaper. It is produced in India only by Serum Institute of India. And it's a very good vaccine. Okay, it is a quadrivalent vaccine, protects against 6, 11, 16, 18. 6, 11, 16, 18. It's India's first indigenous HPV vaccine produced by your Serum Institute of India, quadrivalent vaccine. 611 protects against genital wart, 1618 protects against CA cervix. And this has been used recently to prevent in a campaign mode in India. We have given this HPV vaccination, started in the campaign to cover adolescent girls of age 14 years. So it's actually for 9 to 14 years, but in our recent campaign, in the recent update, all girls aged 14 years were given one single dose of HPV vaccine as in a campaign mode recently in India. So the vaccine used was Cervavac. So you can get questions based on Cervavac. So Cervavac is the first indigenous HPV vaccine in India, quadrivalent, protects against 6, 11, 16, 18. The age group it's mainly targeting adolescent girls of 9 to 14-year age group. Slowly, this vaccine will be introduced in the national immunization schedule. That's what the government is trying to do. As a beginning or as a pilot kind of thing, a campaign was organized and almost all girls in India of 14 years were given one single dose of HPV vaccine. Okay. Moving on to the next question. During the Mahakumbh Mela, the government set up health care campaign, set up mobile medical units for surveillance. Syndromic surveillance is done for fever, diarrhea, respiratory symptom. What is the primary reason to do this? So any campaign or any Mahakumbh Mela or things like that, you have certain surveillance going on. Why? Is it to confirm individual diagnosis with additional tests? No, that is not the aim. To reduce the medical personnel? No. For immediate quarantine of symptomatic individuals? No. The primary reason, these are all done, but the primary reason is to detect warning signs of a disease outbreak. When you have a crowd or when you have something called as like Kumbh Mela or something, there is a chance for outbreak. So the surveillance is basically to detect the outbreak soon, okay, to detect the warning signs of the outbreak so that you can do the intervention then and there. We don't want the outbreak to spread and become an epidemic or a pandemic. Of course, we don't want that to happen. We need to find it at the correct time and do the intervention. Only then the outbreak investigation is of any use. So your surveillance system is mainly to detect the onset of a outbreak. What is this? The name is already there. What is the program? What's the logo? This is the logo of your IDSP, Integrated Disease Surveillance Program. Now we have something called as an IHIP, that is Integrated Health Information Platform. Your IDSP, now we have the real-time updated disease surveillance program under the IHIP. Now the IDSP is merged into the IHIP platform. So basically, IDSP is the Integrated Disease Surveillance Program launched in 2004. The main aim is for early detection and rapid response to outbreaks. It is implemented by your NCDC, National Center for Disease Control. Basically, in IDSP, it is surveillance for certain diseases. So, what are the diseases? There's a list of diseases provided by the IDSP itself. For example, we have malaria, dengue, chikungunya. Mostly the diseases that has a chance to become an outbreak. Other than that, we even have snake bite, rabies. Those things are also included in the IDSP. So we have certain diseases list, and from every institute, whether it's private or public, whether it's a health center or a sub-center or a PHC or a CHC or a medical college, they are supposed to do this weekly reporting of the diseases that came to their hospital or their particular health center. Okay, so reporting is being done through 3 forms. We have S, P, and L forms. S is syndromic, that the form you correct from the subcenter and all the syndromic forms, and P is the presumptive, that is what the clinician diagnosis, and L is your laboratory. From lab also, if it's a medical college, from lab also you can see chikungunya, 10 tests were done, 1 person was positive or 0 was positive. So that data every day or at least on a weekly basis, you have to update to the district level IDSP. So this is basically about the IDSP. And what is RRT? RRT is Rapid Response Team. They are responsible for investigating outbreaks under the IDSP. Okay. That's about IDSP. Moving on to the next question. A farmer presents with high-grade fever, rash, vomiting, retroorbital pain, myalgia since 5 days, and is suspected to have dengue hemorrhagic fever. Which of the following investigations can be done for the diagnosis? So you have viral isolation of Aedes albopictus culture, RT-PCR, dengue NS1, and anti-dengue IgM ELISA. What is the test or investigation which you're going to order for diagnosis? What's the clue here? This is the clue here. Since 5 days. Why am I saying this 5 days? Because you have two tests mainly for a diagnosis. One is your NS1, dengue NS1 antigen. The other one is your IgM ELISA. Dengue NS1 antigen should be used within first 5 days. Okay. Sorry, it becomes positive within the day 1 to day 5. For IgM ELISA to become positive, it is usually you get positive after the 5 days. So since the patients came to you within first 5 days, go for NS1 antigen. If the patient comes on say 6th day, 7th day, or anything after 5, you go for IgM ELISA. Okay. Mosquito, identification of mosquito is important again. It is a image-based MCQ. What do you see here? Dengue mosquito, Aedes aegypti, also called as the tiger mosquito. It has, white markings on the thorax and also the legs, everything. There are white stripes that will help you to identify it. And it breathes in clean, stagnant water. Then the flight range is usually short. It cannot fly for very high. Maximum up to 100 meters only the Aedes mosquito will fly. But the eggs can even survive for months and years, even in dry conditions. It's a vector for dengue, chikungunya, which all? Yellow fever, Zika. Okay, many diseases, all these diseases, the vector is Aedes aegypti. What are the vector indices? We have house index, container index, Brutto index. These are the different vector indices for Aedes. House index is to see how many out of the houses inspected, how many houses are positive. That is house index. Out of the total containers inspected, how many are positive is the container index. Brutto index is the most important one, which can be asked to you. It is total number of positive containers from the houses inspected. That is your Brutto index. Okay. So Brutto index more than 5 is indicated of risk of dengue transmission. Moving on to the next question. Now, before the next question, just one update from dengue about a vaccine, that is Qdenga. See, Qdenga is the latest dengue vaccine which has been kind of approved. It is a live attenuated vaccine developed by the Takeda, and it's a tetravalent, live attenuated tetravalent vaccine. The main, the advantage is that it is independent of whether or not you had a dengue infection before, because we have a dengue vaccine. We had another vaccine is there. This is dengue vaccine, but you need to have a pre-vaccination testing because it has certain seroconversion issues. So it cannot be given to, there is risk in seronegative individuals with the dengue vaccine. But this Qdenga doesn't have any issue like that. There is no such major restriction. Like you don't have to know whether the patient is developing dengue, has already had dengue or did not have dengue, nothing like that. So Qdenga is in a way superior to dengue vaccine. So this is the latest vaccine, which is the talk of the town now, Qdenga. It's a live attenuated tetravalent vaccine. Moving on to the next question is about ICDS. 3-year-old child attending Anganwadi center enrolled under the ICDS scheme. Supplementary nutrition is provided to bridge the gap between recommended RDA and the actual intake, which is correctly represents the nutritional supplementation for a normal child 1 to 6 years under ICDS. Again, simple question, read the last line. What is the nutritional supplementation given through ICDS? So through which centers? Anganwadi centers for a child in the age group 1 to 6 years. You have 200 kilocalorie, 20 gram protein, 300 kilocalorie, 15 gram protein, 500 kilocalorie, 25 gram protein, and none of the above. What's the answer here? See, the answer here is none of the above. Yes, the child with 1 to 6 years of age, the calorie is 500. Okay. But what about the protein? Usually the protein is 12 to 15 gram of protein. So the option we have is 500 kilocalorie with 25 gram. This is wrong. Because of that, we have to go for the option D, none of the above. So about ICDS, what is ICDS? This is the logo of ICDS. Services are given to Anganwadi. ICDS is nothing but Integrated Child Development Services Scheme. ICDS logo is important. We have the beneficiaries, children 6 months to 3 years, child 3 to 6 years. You have the severely undernourished SAM child, pregnant woman, lactating mother, adolescent girl. You need to know the energy and the protein provided from Anganwadis as through this ICDS program. So for children 6 months to 3 years, we give 500 kilocalorie and 12 to 15 gram protein. It's usually given as take-home ration. 3 to 6 years, 500 kilocalorie and again 12 to 15 gram of protein. What cooked meal in Anganwadi? Because these children come to Anganwadi, right? They get non-formal education in the Anganwadi. They get food from the Anganwadi. If it's a SAM child, 500 kilocalories is not enough for a SAM child. There you have to give 800 kilocalories. And the protein also, of course, it is more. 20 to 25 gram protein is needed. Your 12 to 15 gram is not enough. That is actually a double or an extra ration. For pregnant and lactating mother, you give 600 kilocalories being provided from the Anganwadi and 18 to 20 grams of protein. Adolescent girl again gets 500 kilocalories, 18 to 20 grams of protein. How do you remember this? Remember 5, 6, and 8. 500 kilocalorie for a normal child, 600 kilocalorie for a mother. But for a SAM child, he needs more than both these normal child and mother. So he needs at least 800 kilocalorie. So 5 for normal child, 6 for mother, and 8 or 800 for the SAM child. And this is the requirement that is being met from your Anganwadi. So 1/3 of the daily calorie requirement and half of the daily protein. So 1/3 for calorie and half of protein requirement is what is being provided for that particular age group or for that particular beneficiary from the Anganwadi. This also is a repeated, PYQ MCQ question that has been asked. 1/3 calorie, half protein. I hope that is clear. Moving on to the next question. So what do you see here? What is the treatment of choice for the patient's condition depicted below? What is this condition you see here? What is the facies known as? This is your leonine facies. Lion-like or leonine. You see in which is the condition we are talking about? Leprosy. To be specific, this is multibacillary leprosy. So the question is, what is the treatment of choice for patient's condition given below? Again, leprosy question. The leprosy logo is examiner's favorite logo. I would say the examiner's favorite logo, whether it's INICET or NEET, is leprosy. That logo has been asked multiple times, not just logo. We have the mascot, the two girls, the Sapna and the Meena. I'll just show you. So this is the NLEP logo. You see an amputated thumb, a rising sun, and a lotus here showing purity and the inclusion of the leprosy patient. There shouldn't be stigma. The patient should be included in the community. He is also a useful member of the community. Now the two mascots we have. This is Meena. Meena is basically a UNICEF girl with a pink dress and a parrot. Is a UNICEF mascot. She's not just for spreading awareness for leprosy. He's also representing many other things like girl education and girl empowerment also. But commonly we say for leprosy. Who's she? This is your Sapna. This is the Indian version. Okay, Sapna is the girl mascot for leprosy who spreads awareness about leprosy and basically to reduce the stigma and all that. And we have a awareness campaign for leprosy, which is Sparsh. Sparsh means touch, right? Sparsh is a leprosy awareness campaign we have. So now coming back to the question. These are all lesions of leprosy. Okay. Leprosy lesions can be, hypopigmented patch. It can be reddish patches. You can have different multiple presentations for leprosy, but hypoanesthesia is an important feature. Okay, patient won't be feeling the touch. Hypoanesthetic patch is a major, the clinical feature of the rash of the leprosy. So two things I have to teach you here with regard to leprosy. This is a recent update, might not be there in the past. We have revised classification for leprosy and treatment regimen also changed. So what is the revised classification of leprosy? Two types of leprosy you have. What is it? Paucibacillary, that is PB, and multibacillary is MB. Paucibacillary leprosy is if you have skin lesions of 1 to 5. Number of skin lesions is 1 to 5, it becomes paucibacillary. If you have more than 5 lesions, it becomes multibacillary. That is with respect to the number of lesions. Second criteria is nerve involvement. Initially, we used to say one nerve involvement is pauci and more than one is multi. Now that has changed. That is the update that I wanted to talk about, or I wanted to remind you. Paucibacillary has no nerve involvement, that is 0. If even one or more nerve, that's it. Even if one nerve is involved, it becomes a case of multibacillary. So if there is nerve involvement, you are dealing with multibacillary leprosy. It is not paucibacillary leprosy. Okay. So 1 to 5 lesions and no nerve involvement is pauci. More than 5 lesions, or even if there is one nerve involvement, that becomes a multibacillary leprosy. Last one is your slit skin smear. If it is negative, course, it is possibacillary. If it's positive, it becomes multibacillary. So this is the revised classification of leprosy. Please follow this. This has been asked, and this is a kind of a recent update. Now, how do you treat? See, treatment regimen has also been revised. Revised treatment regimen for leprosy. You have two types: possibacillary, multibacillary leprosy. Initially, for possibacillary, we had 2 drugs, and multibacillary, we had 3 drugs. Now that has been changed. Whether it is possi or multi, the treatment, the drugs are the same. Which are the drugs we give? Dr. C is my mnemonic. D is for dapsone. R is for rifampicin. C is for clofazimine. So you give Dr. C, whether it is possi or multi. But if it is possi, you give the treatment for 6 months. If it's multi, you give the treatment for 12 months. So that is a major change here. 3-drug regimen, rifampicin, dapsone, and clofazimine. Or you can remember it as Dr. C, D for dapsone, R for rifampicin, and C for clofazimine. These are the 3 drugs given in the multi-drug treatment regimen for leprosy. Possibacillary, give for 6 months. Multi, give for 12 months. That is a major change here. Okay. We'll move on from leprosy. We're going on to the next question. So, legal transfer of parental rights of an abandoned child to a couple is termed as foster care, remand home placement, adoption, cross-sell placement. See, legally, if a parental rights are being given for a couple of an abandoned child, that becomes adoption. Adoption is where the parents become the legal guardians of that particular child. So adoption is where you give the legal transfer of rights. What is foster care? It's just a temporary care. Okay, there is no permanent legal parental transfer. Temporarily, you put the child under the care of a couple or anybody. That becomes foster care. Remand home is a place where the juveniles are held during the trial. Once the trial is happening, suppose somebody is an offender. We don't know whether he is an offender or not, but he has been accused of a crime. When the trial is happening, the child is kept in the remand home. Once the offender, the punishment has been declared, we send the child to cross-sell placement, that is rehab institutions where you keep adolescent people less than age of 18 offenders. That is your cross-sell placement. Okay, moving on to the next question. Ujjavala scheme primarily targets. Again, I'm back with schemes and national programs. So what is Ujjavala scheme? I'll give you more confusion with similar names. We have Ujjavala, we have Ujjala, it's not Ujjala, sorry, Ujjala and Ujjwala. So Ujjavala is there, Ujjala is there, Ujjwala is there. We'll see each one, okay? So Ujjavala scheme is basically for preventing, it's by Government of India, an effort to prevent trafficking of women and girl from commercial sex exploitation, as well as rescue and rehabilitate and reintegrate them. So 3 R's. So women or girls who are being, taken to commercial sexual exploitation, we have to prevent that. For that, we have the Ujjavala scheme, and it's not just prevention. Suppose somebody is being exploited commercially, you have to rescue the child, rehabilitate and reintegrate them. So 3 R's are there: rescue, rehabilitate and reintegrate. So that is basically a Ujjavala scheme. Okay. Next is Ujjala. Ujjala. Jala means what? Jala is light, right? Lighting, Jala. So Ujjala is basically lighting a house with LED bulb. Okay. So Ujjala is lighting up every Indian household with provision of LED bulbs. Why? LED bulbs actually saves money, saves energy, and we can be part of that, saving electricity for the nation. So that's Ujjala. Ujjala. Jala means light. So lighting up your house with LED bulbs is Ujjala. Now, what is Ujjwala? Ujjwala is Pradhan Mantri Ujjwala Yojana, where women are given LPG cylinders. Why? LPG is a clean fuel. No indoor air pollution, nothing. So clean fuel gives better life. So Ujjwala is where LPG cylinders are being provided to women. So that is Pradhan Mantri Ujjwala Yojana. Okay. Question was Ujjavala. Ujjavala is mainly preventing child trafficking. Okay, so that is option C. I will move on to the next question here. Following a health education session, a patient develops a favorable disposition towards lifestyle modification without necessarily gaining new knowledge or skills. This change most closely reflects which domain of learning. So basically, they're asking which is the domain of learning which involves lifestyle modification and behavioral change and attitude change. Is it cognitive, affective, psychomotor, behavioral? So the answer here is actually affective. Option B, effective, is the correct answer here. So which are the domains of learning? Cognitive means is your knowledge or your thinking domain. Okay, so basically we have three domains of learning. One is your knowledge-based thing, that is the cognitive. Second one is your attitude and your feeling-based domain, that is affective. And third one is your psychomotor, that is your skill. So an example for knowledge-based thinking would be, I teach you about ORS. So you are correctly able to explain the steps, or how ORS is being prepared. You know the theory part very well. That means your which domain is working there. That is your knowledge or your thinking or your cognitive domain is working. Second one is effective. Effective is I try to incult or I try to change your attitude. I give you motivation or things like that, becomes your effective domain from the heart. That is effective domain. Okay. For example, a smoker developing a positive attitude towards quitting smoking. I give health education to a smoker, and finally, after my class, he's like, okay, ma'am, I'm ready to try to quit smoking. That becomes your effective domain. The third one is psychomotor domain. That is, you have the knowledge, you have the effective domain. Now you have to apply it. You know the skill. You're practically doing the thing. That is psychomotor domain. For example, say a nurse administering a vaccine. You know the knowledge, you know the everything, but you need to know the skill. No, you have to have that skill to give a vaccine. Suppose it's an intradermal vaccine. How do you give that vaccine? What's the angle to be placed? How will the blood come? All those things comes under the psychomotor domain. So these are the three domains of learning. Once again, we have your knowledge, affective and psychomotor domain. Okay. Now let's take up the next question. So an urban household is assessed for socioeconomic status using a scale that considers education and occupation of the head of the family along with income. Which scale is being applied? So they are asking you which is the socioeconomic status scale here. Uday Bohr scale, Kuppuswamy and Atson scale. So which is socioeconomic scale for urban household, and the scale is making use of which are informations: education of the head of the family, occupation of the head of the family, and income of the family. This is the question is talking about your Kuppuswamy scale. Sorry, I just lost it, right? So it's a Kuppuswamy scale is the correct answer here. So basically the question is asking which is the socioeconomic scale you use in an urban household. It is Kuppuswamy scale. It is assessed using three variables. One is the education of the head of the household, occupation of the head of the household, and income of the family. Education and occupation of the head of the household and income of the family. These are the three variables in a Kuppuswamy. So what about your Uday? Where is it used? Uday scale is used in rural settings. Okay, rural household or rural population you use Uday Kuppuswamy is for urban population. There is something called as Bohr score. We have Bohr committee. Different committees are there. I'm not going into that detail. That can also be a question for you. But I'm already crossed the 2-hour limit, but we have a few more questions to discuss. I'll try to finish it fast. Okay. So a government fund was established to support initiatives aimed at safety and dignity of women, including prevention of violence. Fund is known as Beti Bachao, Ujjwala, Nirbhaya, Poshan Fund. See, a fund from the government aimed to safety and dignity, aimed to improve the safety and dignity of women is named after our Nirbhaya. So the fund name is called Nirbhaya Fund. So Nirbhaya Fund was established by Government of India in 2013 after the Delhi gang rape case, and the Ministry of Women and Child (WCD) is the major nodal ministry for this administration of this fund. And we have something called as one-stop centers or Sakhi. Sakhi is friend in Hindi, right? Sakhi centers for women who are affected by violence and all, rape victims or any violence victims. They have it's kind of a rehabilitation center for them, shelter home for them. That is called as the Sakhi Center or One Stop Center. These are all funded from this initiative. From Nirbhaya Fund only the money comes. Okay. And what is the emergency response system we have? This is the 112 helpline. There's a 112 helpline, and you have something called as the Safe City projects for women. All these are supported by the the Nirbhaya Fund, and that is the nodal ministry is not health, it is Ministry of Women and Child Development or WCD. I hope that is clear to you. We'll move on to the next question. So this is the the Women Empowerment Scheme and then the Nirbhaya Fund. See the logo. So match the following methods. This is from vector control. So match the following methods of mosquito control with example. You have biological control, chemical control, environmental control, mosquito larvicidal oil, Bacillus thuringiensis, source reduction, larvivorous fish. How do you match? So we'll just match. Okay, biological control is from the examples you have here. Which one? Sorry, not this. Biological control is your two things come under biological control. Which are they? Your larvivorous fish as well as your BT, Bacillus thuringiensis. Both are examples of biological control. So BT is there. Then your fish, larvivorous fish is there. Chemical control is your oil. Larvicidal oil is an example for chemical control. Environmental control would be source reduction. Now, what is IVM? IVM stands for Integrated Vector Management, where you're actually combining different methods, your environmental, biological, chemical, personal protection. All these things are combined in the integrated vector management. That idea was from WHO only. Our program is have adapted to this IVM or the integrated vector management. Next question: most effective long-term strategy for control of vector-borne diseases. So you have chemical, biological, environment, genetic control. See, the question is long-term strategy. So which is going to be effective on the long term? It is obviously it is the environmental control. You have to reduce the source of the vector. Source reduction or environmental control is the primary or the most effective long-term strategy in case of vector control. Hope that is clear to you. We'll move on to the next question. You see a beautiful vector here. Which disease is transmitted by this vector? What is the vector and which is the disease? Options: malaria, dengue, visceral leishmaniasis, and J. Japanese encephalitis. Which is the vector here we are talking about, or what you see on screen is the sandfly. To be specific, it is the female sandfly. Phlebotomist. So female sandfly is a vector for which of the following diseases? It is leishmaniasis or visceral leishmaniasis is the answer here. Okay. So sandfly also is an image-based MCQ. Plus, that's among the all your the NBBDCP diseases, vector-borne diseases. This is the only one which is spread by sandfly. Plus, most of them are by mosquitoes. So some one-liners about Kala Azar or leishmaniasis. Constipation, leishmania, Donovani. Vector we already discussed, female sandfly. Drug of choice for leishmaniasis in India is liposomal amphotericin B. Tell me which is the investigation of choice. Investigation of choice for visceral leishmaniasis is not RK39 antigen test. It is your LD bodies, demonstration of LD bodies in splenic aspect or anything. Leishmania Donovani bodies, that is the investigation of choice. But we have RK39 antigen test, which is commonly used. Why? It's a card test. It's a very easily done test. So in rural settings or in community and field settings, you go with this card test, RK39 card test. But investigation of choice is not that. Investigation of choice is always your demonstration of LD bodies. Okay. And where do sandflies breed? We talked about the breeding of Aedes mosquitoes. We know it is in the clean stagnant water like your coconut shells or any containers or even the flower pot and all that. Sandfly breeds in dark, humid places like in crevices and all that. And it has something called as a hopping flight. It was about sandfly. We'll move to the next question. So following a major earthquake, there is concern about outbreaks of communicable diseases in the affected population. So there's a disaster and you are concerned about chance of outbreak in that particular population. As part of public health response, mass vaccination is considered. According to WHO recommendation, which is the following vaccine is routinely advised in such post-disaster setting? So options: typhoid, cholera, tetanus, and none of the above. See, the answer here is none of the above. The question itself is kind of a misleading question. In case of an outbreak, once there's a disaster, sorry, not an outbreak, if there's a disaster, of course, there is chance for outbreaks. But your primary measure is not to vaccinate people. We can't do mass vaccination. That will in effect create a false sense of protection. It's going to backfire. So always priority after disasters is for your safe water, sanitation, shelter, okay, and of course surveillance. If there is an outbreak, you have to identify it fast and do the necessary measures. And also, if at all you need to give a vaccine, it's usually a measles control. Because if it's a children area and there's an outbreak of measles, if the population is at risk of developing or of a measles outbreak, if it's not a vaccinated population or that vaccine you can think about. Okay, it's not a recommended thing, but you can think about measles vaccine. Other than that, the primary response or priority that has to be given after disasters to prevent outbreak is, of course, safe water, safe sanitation, and proper shelter and surveillance. So, safe water and sanitation is the most important thing. It's not vaccination. You do vaccinate whom? Not the whole population. You give vaccine to the healthcare workers, because if they are going to be involved in certain high risk areas following the vaccine, following the disaster, you have to vaccinate the healthcare workers. Not a mass vaccination, usually not recommended. What do you see here? Another image-based question. Simple chapter. Question usually comes from disaster cycle. So disaster cycle, you have different phases. You have response, recovery, mitigation, and preparedness. So different phases of the disaster cycle are important. And what happens in each phase, especially the mitigation. Mitigation is actually a phase where you do risk assessment and reduction. You don't want to, long-term thing where you have to reduce disease impact before occurrence, that occurs in the mitigation phase. So disaster cycle can be asked. Moving on to the next question here. A battery factory worker. Okay, presents with abdominal pain, anemia, bluish line on the gums. What do you call the bluish line on the gums? Is Barton's line. Barton's line. Which of the following statement regarding lead poisoning is incorrect? They've already told you it's lead poisoning. So which is wrong? Basophilic stippling is a sensitive hematological finding. Is wrong. Okay. Basophilic stippling is a hematological finding, but it is not very sensitive in case of lead poisoning. Porphyrin in urine is useful screening test. Yes. Major environmental source is drinking water from pipes. It is a major environmental source. May produce bluish line in gum. Yes, that is called Burton's line. Okay, so we are talking about lead poisoning. Lead poisoning is an occupational health disease. It is not, you get lead poisoning not just from occupational exposure. There are other exposures, like, for example, lead pipes, water from lead pipes. Then in paints, you have lead. Children, you have, in kids, we have some toys have lead. It shouldn't be there. But if the child is, putting that lead containing toy in mouth and all, child will ingest lead. That is also another source of lead poisoning. What are the clinical manifestations of lead poisoning? We have a mnemonic for that. That is A, B, C, D, E, F, G, H, I. Quickly, we'll write down the mnemonic. A. These are the clinical manifestations of lead poisoning. A is for anemia. Sometimes amenorrhea is also there. B is for two things. One is basophilic stippling. The other one is Burton's line. Burton line is bluish discoloration on the gum you see here. Basophilic stippling is this. Okay. So that is there in lead poisoning, but that is not a very sensitive indicator. So that is B. What does C stands for? C is colic. The patient, the person who's been exposed to lead, coming with lead poisoning, usually comes with abdominal pain, colicky pain. Sometimes they have constipation. So the both C is there. D is for what? Drop. Drop is the D for. E is for encephalopathy. Encephalopathy is usually a finding in children. Encephalopathy is seen in kids with lead poisoning. Okay. And F is for facial pallor. Again, that's anemia only. G, growth retardation. Again, in children affected with lead poisoning, they can have growth retardation. H is hyperuricemia. And I is infertility. Even lead poisoning on a long term can lead to infertility. These are all the clinical manifestations of lead poisoning. Remember the mnemonic? A, B, C, D, F, G, H, I. Okay. How do you diagnose lead poisoning? Of course, you need a history, then you check for the clinical features. Now I'm going to talk about the laboratory test only. Okay. One is for screening, you have CPU, that's coproporphyrin in urine. If it is more than 150 microgram per liter is positive. Screen positive for lead poisoning. Second one, you have ALA in urine. That is aminolevulinic acid in urine. More than 5 mg per liter shows lead absorption. Third test is simply check the level of lead in your blood. If it is more than 70 microgram per liter, and in urine, if the lead level is more than 0.8 mg per liter, it shows lead poisoning. Okay, and once the lead in your blood reaches more than 70 microgram per liter, that is when you start to develop symptoms of lead poisoning. Then you can get, if you take the peripheral smear, you see the basophilic stippling of RBCs. That's also a finding in lead poisoning. Okay, we'll move on to the next question. ESI. What does ESI stand for? Employee State Insurance in India. So, which of the following statements regarding employee state insurance in India is incorrect? It provides comprehensive medical care is correct. Includes contribution from both center and the state is also correct. Workers below a certain wage are exempted from contribution is also correct. Fixed monthly contribution of 300 for low income workers is wrong. There is no fixed monthly amount, like every month give 300 rupees. No, it is not fixed monthly amount. We have a percentage. How much is the percentage of contribution for ESI? So under the ESI Act, the employer has to contribute 3.2 percentage, 3.25% of the wages, and from the employee, how much do you collect? Has to give 0.75% of the wages. This is the contribution from the employer as well as employee. As per your ESI Act, it is not a fixed amount. So ESI Act 1948, very important question, repeatedly asked. Some of the important points, we'll just write it down quickly. ESI Act is from 1948. It's actually a social security and health insurance scheme for workers. And under this, we have different benefits. We have the sickness benefit, then you have maternity benefit, disablement benefit is there, dependent benefit is there, and funeral benefit is there. Due to lack of time, I'm not going to explain each one of this, but it is important. Please go back, read your primary notebook, whichever you're learning, study about the SI Act. Very simple area and a scoring area, but if you miss that, it will be a sad thing. So it's actually a quickly scoreable area. So ESI Act, please learn the ESI Act. How much is the cash benefits? What do you mean by sickness benefit? What is maternity, health benefit? All those things, please learn. And the contribution, I've already told you, 3.725% of employer and 0.75% from the employee. Now, we have the unorganized sector, the gig workers, the Swiggy, your Instamart, your Amazon, all these online delivery platform workers. That's a huge chunk of people in India right now. But unfortunately, they are not coming under the ESI Act. The ESI Act is for the organized workers. These unorganized gig workers or platform workers doesn't get covered under the ESI Act. For them, we have a new portal now. I've discussed it in the previous live also. It's called as e-Shram portal. So e-Shram portal is mainly for the unorganized sector workers or the gig workers. Okay. So under the e-Shram portal, they have to register and they get some, for accident and all, they get a kind of 2 lakh coverage under the e-Shram portal. So this is something new, which is mainly focusing on the gig workers or the platform workers or the unorganized sector workers. Next question: which of the following establishment is not covered under the ESI? Small factories using power, non-power factories with more than 20 workers, newspaper establishment, defense. Defense is not covered under the ESI. Okay, as well as your what I told you now, the unorganized sector doesn't come under the ESI. Moving on to the next question. Ergonomics primarily deals with optimizing interaction between worker and workplace. Which of the following is not related to ergonomics? Designing machines as a part of ergonomics. Improving efficiency of man and machine is a part of ergonomics. Adapting job to worker is a part of ergonomics. Criteria for primary healthcare. That's completely wrong. What do you mean by ergonomics? Ergonomics deals with fitting the job to the worker. That is ergonomics. Simple terms. I'm a person who is using laptop every day. Okay. So I need to ergonomics for me is every day I'm sitting. So I need some back support here. Otherwise, I'll end up with musculoskeletal pain and everything. And the laptop I'm placing, I can place it on a stand or something. So I don't have to, strain my eyes. So I am actually fitting myself to the job or fitting my job to the worker. That is what ergonomics is all about. It's fitting the job to the worker. Now we have another similar term. That is, what do you mean by emporiatrics? Sounds similar to ergonomics, but this is actually travel medicine. It's a science of travel medicine. It basically deals with the health risks during travel, the vaccinations needed for travelers, prevention of travel-related diseases. All these comes under your Emporiatics. So ergonomics and emporiatics are two completely different things. Moving on to the next question of the day. Population remains genetically stable across generation in absence of disturbing factors. This principle is known as, it is called as population genetics equilibrium, also called as the Hardy-Weinberg equilibrium. This basically says that when there is no disturbing factors like can be mutation, migration, or large population size, there is no much disturbing factors. The genetic stability of the population remains kind of constant. There is an equilibrium in the genetic stability of the population from generation to generation when there are no outside disturbing factors. This is called as the Hardy-Weinberg equilibrium or Hardy-Weinberg law. Okay, that is a question from genetics area. Again, one more question from genetics. Improvement of human well-being by modifying the environment, such as nutrition, sanitation, education. Basically, improving human well-being by modifying the environment around him or her is called as eugenics or euthenics. See, it is euthenics. Environmental factors when you're modifying so as to improve the human well-being, that becomes euthenics. When you're trying to modify the genetic factors, that becomes eugenics. Eugenics is of two types. One is positive eugenics and negative eugenics. Positive eugenics is like encouraging reproduction of desirable groups. Okay, that is positive eugenics. It's like you take people with all very good genes, and you promote mating of them. That becomes encouraging the population of desirable group. That is positive eugenics. Negative eugenics is the opposite, discouraging the reproduction of undesirable groups. Both are not ethically correct. And what we prefer is euthenics. Euthenics is making the environment better for the human well-being. Like you provide good sanitation, good nutrition, good education. That it will still improve the human well-being, right? That is euthenics. Okay. Genetic counseling is basically, you advising families about the genetic disorder. That's what I mean by genetic counseling. That's the option number 4. Next question. Most commonly abused substance in India. Cannabis, tobacco, heroin, amphetamines. Which is the most commonly abused substance in India? It is what? Tobacco. It's not just smoking tobacco. We have the smokeless tobacco also. So basically, it is the tobacco that's the most commonly abused substance in India. I put this question so that I can talk about an act which is called as the, what is this? You have seen this board everywhere. Like if you smoke, fine is there. You cannot smoke in public areas and all that. This is coming under the COTPA Act of 2003. COTPA Cigarette and Other Tobacco Products Act. So under this act, there is certain important points. One is no smoking in public places. That is one thing. Second one is you are not supposed to sell or sell tobacco to minors or children less than the age of people less than the age of 18 years. You do not sell tobacco. That is actually punishable under this particular COTPA Act. Third one is 100-yard rule. 100-yard rule says that sale of tobacco within 100 yards of an educational institution is prohibited. That is the 100-yard rule of tobacco. And then remember, it's a 2003 Act. So the Act which says with respect to tobacco is COTPA Act. Now, what is this? This is a logo of a program. We have the National Tobacco Control Program, and the logo is this: choose tobacco, choose life and not tobacco. This is the logo of your National Tobacco Control Program. Next question. Among psychiatric disorders, the maximum contribution to DALI is from schizophrenia, depression, alcohol dependence, bipolar. See, for psychiatric disorders, the maximum contribution to DALI is from depression. Okay. What is DALI? Disability adjusted life years. You get DALI by adding YLL plus YLD. Years of life lost plus years of life lived in disability. So it's an indicator which combines both mortality as well as morbidity or disability. That is DALI. And depression contributes maximum DALIs as far as your mental health issues are concerned. Next question is about the mental health program. So, which of the following is not a core component of district mental health program? Options are training of health professional, public awareness, record keeping, mass screening. See, mass screening is not a part of your district mental health program. Mass screening is not, as of now, it is not a component. It's not a core component of your district mental health program. All the others that they have mentioned are components of district mental health program. What is this? This is a logo of the sunflower. It's a logo for your national mental health program. This was program launched in 1982 by the government of India to ensure what availability and accessibility to minimum mental health care for everyone, and basically emphasizes on the integration of mental health service at the primary healthcare level, so that you can screen and find out people with mental health disorders at the primary level itself. That's the main thing of your mental health program. And district level, you have the district DMHP or district mental health program. Next question, which is following is the correct sequence of various components of the communication process? You have receiver, message, channel, feedback, sender. Simple question. Answer is option C. From the sender, the message has to go through a channel to the receiver, and from the receiver, I have to get a feedback. So if I'm taking class, I'm the sender of the message. I'm sending you the message. Message is going through the channel, through the YouTube channel. You sitting on the other side is the receiver. And after class, you give me a feedback, whether the class was good, bad, what should be improved. That's the feedback. That completes the communication process. Without feedback, that is not actually complete. So from the receiver, sorry, from the center, message has to go to the receiver through a channel, and finally, I should get a feedback from the receiver. That is the whole communication process. Next question. Number of ASHA home visits after home delivery. We are talking about home-based newborn care, HBNC, another program where the ASHA has to go to the house of the newborn and check on the child. Okay, so how many visits should ASHA make in case of home delivery? See, in case of home delivery, she has to make 7 visits. Okay, 7 visits in case of home delivery and 6 visits in case of hospital delivery. See, when you see the visits, it should be done within the first 42 days of life. So in case of home delivery, the first visit is on the day of the delivery. When the child is born at home, that is the first visit. But when you take a child who is delivered at a hospital, first 3 days at least, or at least for 48 hours, child is in the hospital. So that is not, there is no point in talking about the home visit of a child when the child is admitted in the hospital, right? So for hospital delivery, it is 6. For home delivery, including the first day of the visit at the home, it is 7 visits. Now we have something called as home-based care of young child, HPYC. In that, there are number of visits is 5 actually. This is not for HPNC, it's HPYC. So care of young child, this is 5. So 7, 6, 5. 7 in case of home delivery, 6 in case of hospital delivery, and 5 visits in case of young child. That is not HPNC, that is HPYC. For the sake of mnemonic, I'm just telling it along with it. Okay. So these are the different visits as per your home-based newborn care. First visit is, this is for a hospital delivery. 6 visits are given. So on the day 3, so mother and child after delivery comes back to the home. After 48 hours, usually normal delivery, we discharge the patient, right? So 3rd day, 7th day, 14th day, 21, 28, 40. These are the 6 days in case of home visit by ASHA as per the home-based newborn care program for a hospital delivery. If it's a home delivery, along with this, you will also have a day 1 visit. So it makes the total number of visits as 7. Now, why should the ASHA go to the houses? See, it is basically to counsel the family members. It's a new family. The mother doesn't know how to feed. And ASHA basically goes and educates the child whether the mother is feeding properly, whether there are any danger signs, about the timely vaccinations to be given, then how to take care of the child. Like, for example, sanitation and washing has to be done before the caregivers hold the child. So, and what is the age appropriate play and communication with the child? All these mothers and the caregivers might not be knowing. So it's ASHA who has to give the awareness. For that, we are having this home-based newborn care. So home-based newborn care is HPNC is basically from birth to 42 days. And ASHA is getting an incentive for this. She gets 250 rupees per newborn if she has completed all the scheduled visits. Now, once this program was success, the government thought, okay, newborn care is not just enough. We'll do the same thing for care of young child also. So they started the HBYC, that's home-based care of young child. Here, the ASHA has to visit the child from 3 months to 15 months. And we have 5 visits at 3, 6, 9, 12, and 15. Each month, she has to visit the child at least once. Okay. So 5 visits are there for HBYC. Okay, we'll move on to the next question. So I've reached the last question of the day. So what is an USHA? You know about ASHA, right? ASHA is in rural. So in urban also we need someone, that is the USHA. USHA is the urban social health activist. So USHA typically covers a population of how much? 2,500 to 3,500, 1,000 to 2,500, 4,000 to 5,000, or 5,000 to 10,000. The answer is option B, 2,500 to 3,500. That is the population coverage for USHA. So USHA is your urban ASHA or urban social health activists. ASHA stands for accredited social health activists. The counterpart of ASHA, who's there in the urban area, is the USHA. So she is under NUHM. NUHM is National Urban Health Mission, not the rural one, and covers a population of 2,500 to 3,500. Preferably, the area is usually a slum area or a vulnerable population. Now, before we wind up the session, we'll discuss the population norms for what is the population of a sub-center, health and wellness center, and your community health center. All those things are important. And who decides all this? We have a guideline. We have the IPHS standards. So IPHS standards are updated, at certain years. And based on the standards only, we say, okay, one PHC or one sub-center is for 5,000 population. All these norms, or a PHC should have this much doctor, or a CHC should have this much number of specialists, this many lab technicians. All those are, told in your IPHS standards. So that's the basis for what I'm going to tell now. So quickly we learn. We have a plain or rural population, and you have tribal, hilly, and hard to reach areas. Sorry, we'll write once again. So I'll write the health facility name. Then for plain or rural area, you have a particular population norm. For tribal or hilly areas where the houses are far apart, you cannot have the same population norm as a plain. No, because we don't have that much houses together in a tribal or a hilly or a hard to reach area. And for urban, we have, now latest we have urban norms also. Starting with your sub-center. Sub-center, what is the population norm in plain? 5,000. One sub-center for 5,000 population. If it's a plain area, if it's a hilly area, it is 3,000. For your primary PHC level, it is 30,000 for plain area and 20,000 for your hilly or hard to reach area. CHC is for 1 lakh, 1.2 lakh for plain area and 80,000 for your hilly area. Sub-district hospital is for 5 to 6 lakh for plain area, and hilly area we don't have a particular number. It actually depends on the terrain. Okay, and district hospital also 10 to 15 lakh is for your plain area, and tribal area again depends on the district. Now you have your urban health and wellness centers. The population is 15,000 to 20,000. That is the urban area. And you have urban community health centers, that is for 2.5 lakh population. These two are latest updates in your latest IPHS. Other than that, rest are all the same. So once again, sub-center for 5,000 in plain area and 3,000 for tribal area. PHC 30,000, 20,000. CHC 1.2 lakh and 80,000. Similarly, for urban areas, we have separate numbers for urban health and wellness centers. So that can be either a sub-center or a PHC. I told you, health and wellness centers are nothing but upgraded sub-center or PHCs, renamed as Ayushman Bharat now. So for that 15,000 to 20,000 population for one urban health and wellness center. And for urban CHC, population is 2.5 lakhs. Okay, so these are the different population norms for your different levels of healthcare. So that's all from my side. All the best. And before concluding, I'll just tell you most important topics for INICET exam as far as PSM is concerned. Vaccines. No excuse in that. Vaccines, A to Z, everything, which is a live vaccine, which is a kill vaccine, the national immunization schedule, each, how each vaccines are administered, the cold chain, components of cold chain, everything in and out related to vaccines is very important, repeatedly asked. Second one, epidemiology. Epidemiology, your all the formulas and all the different study designs are important. What do you mean by number needed to treat, number needed to harm? These are all extra things in RCT which comes. No, then the causation criteria, your outbreak investigation, everything from epidemiology is important. Biostatistics is another important area for your INICET exam. NEET-PG usually asks direct questions from biostatistics, but INICET will try to test your knowledge, test your concept. They don't want to know the factual things by heart and you pour it in the exam. Not that way. It is going to test your knowledge, your concept. So biostatistics very important. P-value, types of errors, tests of significance repeatedly asked. We have discussed it yesterday. That is also an important area. Fourth one, national health programs. We have different health programs. Even if you can't study the each and every point of health program, it's fine. Study the logos, important points, important updates, especially the TB, leprosy, HIV programs, very important from INICT point of view. Then all your RCS programs, maternal child health, JSY, JSSK, even what do you mean by your the family plan, the Antara, all those things are important. So these are the main four repeatedly asked important areas for your INICT exam. And so wishing you all the best. Do well and thank you. Good night.